Order, order. Could we welcome you to the Scottish Affairs Committee to help us in our inquiry on problem drug use in Scotland. Just for the record, who you are, who you represent, and anything by way of a short introductory statement. We'll start with you, Mr Powell.
Thank you. My name is Martin Powell. I work for the Transform Drug Policy Foundation. Transform is an international think tank that does three forms of work. One is the international stuff, so we've advised the Canadian government, for example, on legal regulation of cannabis markets. My personal role is looking at drug consumption rooms, heroin-assisted treatment, working with police and crime commissioners and so on. But perhaps our most important work is actually with our Anyone's Child project, which is working with bereaved families across the UK, including in Scotland. And about a week ago, we were outside here on College Green with bereaved families planting 1,500 of these forget-me-not flowers, each one representing someone who has already lost their lives to drugs this year in the UK. 500 of these were sent down from Scotland, including this one, which has the name Eamon written on it, this one, which says Lizzie, and this one, which just has Mum on it. And I think what I'm here today is in the hope that this committee and the work that you do can help make sure that there are fewer Lizzies and Eamons and Mums to put in the ground next year.
Okay, thank you very much for that. Mr Liddle.
Hi, I'm David Liddle. I'm the Chief Exec of the Scottish Drugs Forum. We're an NGO in Scotland funded through a range of sources, including Scottish Government, with an aim of reducing drug-related harm in Scotland. So we undertake a range of work, and some of you visited our offices a couple of weeks ago to see some of that work around our addiction worker training program, peer research. But fundamentally, we're about representing the sector in terms of aiming to improve responses and use resources in the most effective way. And obviously, one of our key concerns, alongside what Martin has said, is the fatal overdose deaths and the continued rise in those, which is a major concern of ours. So we're particularly concerned about aspects around treatment and care and how that can be improved, particularly around issues around suboptimal prescribing of methadone, for example, poor retention rates in services, etc., that can actually impact on that. And obviously we've been pushing for many years around drug consumption and heroin-assisted treatment as well. So that's really it. We're about reducing drug-related harm and obviously working with a range of agencies across Scotland to try and deliver that.
Thank you, and we're incredibly grateful to you, Mr Liddle, for facilitating us the other week and visiting your centre and to speak to some of the centre users. With a very, very helpful experience for us, so thank you for that. Mr Duffy.
Good morning, my name's Jim Duffy. I'm a retired police officer. I was with Strathclyde Police for 32 years between 1975 and 2007. In 2005 I put forward what's called a discussion motion at the Scottish Police Federation Conference that we should have a debate about legalisation of drugs. Following on from the furore that caused, I was approached by a group of people in America called LEAP, which was Law Enforcement Against Prohibition. They are a group of serving and retired police officers, undercover agents, sheriffs, legislators, senators, judges who understand that the war on drugs, as it currently stands, is completely lost and completely unwinnable. We currently have a market across the world which is entirely controlled by criminals. Criminals who care not a jot for the age of the person that buys the drugs, the state of them, whether what the content is, what it's adulterated with. All they're interested in is the money. And we understand that prohibition does not work. So our stance is that now across over 115 countries about the world, we have representatives, much like myself, people who were involved in the justice system, who try to convince people that the way forward is not to follow the current Misuse of Drugs Act, which has been in place now for 48 years and has been an out-and-out failure. There is not a drug-free town, street, village, city, anywhere. Certainly not in this country. Because if there was, there would be a queue of people standing round about it to say, look what we've done, and that's the shortest queue in the world. So we are of the view that what's currently put in place is not working. We need a radical rethink, we need a change. We need to take it away from criminals, we need to take it away from the organised crime groups, we need to legalise, legislate and control.
Grateful, and thank you for that, and thank you for all of you for being so concise and brief. What we're trying to explore today is just criminal justice interventions, just about how effective they are and just what type of criminal justice interventions are currently being pursued by a range of different authorities. I just wondered, to start things off, could you give us some sort of idea just how many problem drug users come into contact with criminal justice interventions? Have you got any idea what these numbers are and what percentage of problem drug using community would be involved? Mr. Liddell, maybe start with you.
Okay. Yeah, certainly in terms of, for example, in prisons, the prison survey in 2017 suggested 36% of people had a drug problem on the outside before entering prison. Now, if you do the rough mathematics around the number of admissions, that suggests probably about 12,000 people have with a drug problem go in and out of prison in a year. But that's very rough. And if you wanted to, give it, I suppose, a scale, that's roughly it. In addition to that, obviously, you have things like the drug treatment and testing orders, which are for high tariff offenders. That's people who would otherwise get a custodial sentence are given drug treatment and testing orders. In 2017-18, there were 525 of those, and as, I think of the overall number of orders, 500 were completed and 168 were breached. You've also got community payback orders with a condition of treatment, and then you've got all of the possession offences, which I think amount to 27,000, and then also possession with intent to supply of 3,877. Interestingly, also, you heard from our addiction worker trainees. We've done a rough look at their criminal histories over the years, and what we find is that for most of those individuals, the offences are mostly shoplifting, housebreaking, and then Misuse of Drugs Act offences, roughly half and half. So that's over the years that we've had 200 odd people through that programme, and that seems to be the breakdown. So I think the engagement with the criminal justice system obviously is significant, probably more so for example, the street users in the big cities where there's much more engagement, say, directly with the police. And then beyond that, obviously, you have arrest, custody, etc., as part of that. So that's roughly it. I don't know whether Martin wants to add to that, because he looked at the similar figures. You've probably.
Overall, according to the Scottish Government, there are about 131,000 people taken into police custody.
131,000?
In 2017-18, and between 11 and 35% of those are dependent on some kind of substance. And that's taken from the Scottish Government's actual drug strategy. You're also looking at 27,000 drug possession offences, 4,000 supply offences, with 12,000 proceeded against in court. And in terms of the prison itself, as you'll be aware, Scotland has the highest rate of imprisonment in Western Europe, 150 people per 100,000 of the population. And on July 21st, I had a look at the stats. There were 8,175 people in custody. And again, in terms of the numbers affected by drugs, 15% of prisoners said they committed their offence to get money for drugs, and 38% were under the influence of drugs at the time of their offence, which again gives you an indication this is a major issue in terms of impacts on the drug using population.
Do any of you know this? Would this be the first contact that these individuals would have had with the criminal justice system? What I'm trying to suggest is it the problem drug use that would lead to that contact, or is there anything that precedes that would be any sort of arrest or stopping by the police at all? Is it the problem drug use that leads to the criminal justice?
Well, I mean, obviously you've looked at routes into problematic drug use, and certainly what, for example, is clear with the young offender population that a significant proportion have been in care. So, it may be other issues actually, relating to other offences have preceded the problematic drug use, but I'm not sure of the exact data on any of that. That's more sort of anecdotally that. People may be involved in particular groupings prior to their problematic drug use, when I suppose their drug use may still be, if you like, more recreational than problematic.
I'm interested to hear from you, Mr. Duffy. Do you think that problem drug use is made worse by this criminalisation?
I think to try and put a kind of proportionality onto it, the last World Health Organisation survey I looked at said there were about 430,000 casual cannabis users in Scotland. You have somewhere between 50 and 55,000 heroin addicts. So those figures combined take you to an area of around about 500,000 people. Now in a population of just over 5 million, that's quite a lot of people. Not all of those people come into contact with the criminal justice system. There are many, many people who use drugs recreationally who will never come into contact with the police system because they have stable backgrounds, they are in employment, they are in stable relationships, they have the money to go and purchase the drugs. The people who come into contact with us are the people without hope, without jobs, who have suffered trauma in their lives, who turn to drugs as a means of escape. Nobody wakes up as a 15 or 16-year-old with the ambition in life to be a drug addict or a heroin addict or become addicted to something. It's something that happens through circumstances and maybe poor choices. So the ones that do come into contact with the criminal justice system, at the moment, that can have a devastating effect on the rest of their life. You get out a conviction for a narcotics offence. As an 18-year-old, you're stopped, you have a joint on you and you get arrested and you get a conviction at court for a narcotics offence. 10 years later, you're a happily married man with 2 children and you take the kids to Disney. You get to American immigration and you don't get across because they see you've got a narcotics conviction. Try explaining that to a 4 and 5-year-old, that 10 years ago daddy had a joint and because of that you can't get to Disney. That's a slightly comedic effect, but it's a reality. It has a huge impact on people's lives.
So what you're saying to this committee, there's a particular profile about those who consume drugs, maybe take them recreationally, and those who have a problem drug use will come into contact with the criminal justice system. Is that what you're
yes.
saying to us today? Yeah. And what are, just from the other two, what sort of impact does that have, therefore, on these individuals who are convicted of these drugs offences? Mr. Powell?
Run through these. So a lot of bodies have looked at this. The Royal Society of Public Health, World Health Organisation, BMA, MCDDA and so on. And these kind of contacts lead to greater exposure to drugs in prison. They sever family and other support networks, sometimes leaving children in care, provide barriers to education and employment, as we talked about. Stigma and fear of arrest actually discourages people from coming forward to help and kills people, to be blunt. One of the families that was out on College Green with us last week, Rose and Jeremy Humphreys, lost 2 of their sons to heroin overdoses. One of them died, they think, because his friends were too slow to call an ambulance because they were afraid of arrest, because they would be criminalised for it. Their other son died later after he'd been abstinent for some years and he relapsed. Because of the fear of stigma and the impact on his career, he didn't seek help and was found alone, having lost his life. So these are very, very real impacts. You also get displacement to other drugs from enforcement. You get criminalisation creating practical obstacles to healthcare professionals delivering, including drug consumption rooms. And finally, if you're trying to educate young people about the dangers of drugs, trying to arrest and punish them at the same time drives them away from that. And again, there's a lot of research I can provide evidence of this as well. So myriad different negative impacts from criminalisation.
But there must be some examples where coming into contact with criminal justice will have a positive impact and benefit for some problem drug users. There must be some evidence that suggests that. I think we saw something on BBC last week, the Cops and Cons project, for example, where it did seem to suggest that this was a means and a way forward for dealing with
Well, I mentioned the drug treatment and testing orders, which have been running for, I think, since the 2000 or thereabouts. And they have proved successful, but for a small group who tend to be the older population, the 35 and over, that's the group that they're particularly successful for. And those are very intensive programs, probably costing around £12,000 per individual. And it's the wraparound support that's the key, and that's the sort of support we should be mirroring across the range of organisations, in terms of treatment and care services. So those work well, and as I said, the numbers of breaches are relatively small. So that's for a group who've committed significant amounts of crime and would otherwise go to prison. Obviously, there are other things like arrest referral programs that you'll hear more about, and there have been diversion from prosecution programs as well, for example, that have worked well. But they're not consistent drug treatment testing orders are available, and of course you've got prison-based treatment services, etc. as well, and through care programs that try to connect people on release from prison, because obviously that's a crucial point, particularly in terms of fatal overdose death. And we've done a lot of work in prisons around supplying people with naloxone, so they have that on release to reduce the risk of fatal overdose.
Did you want to come in, Mr. Duffy?
I think there are a very small number of people who, when they are caught by the police doing something illegal, will learn from it and not do it again. I think by far the majority of people who are caught doing something illegal by the police learn how they were caught and learn not to make that mistake again.
Okay. Right. I know David Duckett was wanting to come in before we move on. David?
Yeah, just very quickly, I mean, obviously, in answer to Mr. O'Shart's earlier question about the numbers, there's quite some quite startling numbers there. But I'm just wondering, because this inquiry is focused on why in Scotland we seem to have a problem more so than elsewhere, I was just wondering what can be done, or indeed what has been done within the current devolution settlement to make the Scottish criminal justice system more constructive in terms of helping problem drug users.
Do you want me to yeah, I mean, I think obviously the drug treatment and testing orders are a distinctively Scottish response, as were the drug courts in Glasgow and in Fife. That's now closed, but they were both, the drug courts and the drug treatment and testing orders were based on that notion that it was far better to actually keep those long-term problematic drug users out of prison at all costs, and it was far cheaper, obviously, even at the cost of £12,000 a year. That's far cheaper than obviously the cost of putting somebody in prison. So those are the more distinctive things. There have been, as I say, arrest referral programs that were developed. Those have largely, in terms of the intensive support, those have largely disappeared now. And there was, for example, in Aberdeen in the past, there was a particular program around diverting people from prosecution where, a social worker went through all of the prosecution papers and picked out individuals to divert away from the court proceedings. So those, I guess, would be some of the more distinctive things that I can think of.
Can I just skip ahead, because I think that brings me on to the question I was going to ask a little bit later. It probably makes sense to ask it now. Is there, what measure of success have those diversion activities actually shown in Scotland, or is it a bit too soon to tell, or is there evidence that shows that the various tactics you've just described have actually had a measure of success?
Well, I think the problem, I suppose, in a sense, is that we're talking about 56 or more thousand people with a drug problem. The drug treatment and testing orders are for about 500 or 600 a year, so they're very specific towards a particular target group. But in terms of the number of orders completed, the last data showed 500 orders were completed, and actually the number breached were 168. Now that, to my mind, with this population who've been using problematically for potentially 20 years or more, is very, very successful. And I think the arguments are around actually replicating that across the whole range of services, rather than necessarily investing a lot more in those particular programs, but they have worked, for this particular group. Okay.
That's the diversion initiatives in particular?
That's the alternatives to custody, which, and then there's also the community payback orders with a condition of treatment. Those are
could
sometimes
we maybe
used
get,
as well.
I mean, if you don't have the numbers to hand, could we maybe get that provided to the committee? What just the measure of success that those have had over time?
Yeah. Okay, thanks. Did you want to come then, John?
Then, Mr. Liddell, just about the social worker in Aberdeen, in the Aberdeen area, diverting folk away from prosecution. I'm just wondering, what criteria would that social worker have used in order to decide one person over another?
It was working with the Procurator's Fiscal, so it was done in conjunction with them. I mean, it would basically, I suppose, in a similar way to the drug treatment and testing orders, it would look at the fact that, more suitable disposal for an individual was actually to work with them in the treatment system as opposed to sending them to prison.
Yeah, sure.
And that actually there's strong evidence, obviously, that those outcomes would be better overall. Yes. I haven't got the actual detail. It was many, many years ago, but I'm still in contact with the person who ran that program, so I could find out more detail. But this is one of the problems that we have, though, with programs that work well, and actually are successful, but then aren't replicated and actually then just disappear because of lack of funding
that
or
would be
other
interesting
reasons.
to hear. Thank you.
John Lamont.
How the criminal justice system interacts with the health service and whether there are interventions from the health system into the criminal justice system and whether you think they're being used effectively.
Is that to me again? I guess it probably is, but I hesitate, I suppose, to go back to the drug treatment testing orders, but that is the one example where basically there is a significant health component to that. For example, most people on the drug treatment and testing orders would go on opioid replacement therapy, so they would be on methadone, and actually that the condition is that you comply with the order. It's not that you would stop using drugs. So that's a key feature of those programs. They operate in a harm reduction fashion, and actually one of the issues then has been that people at the end of those orders have to then move into mainstream treatment, and there's sometimes been problems of that continuity of care at the end point, which is an issue around the health service. There's obviously health involvement in custody suites, for example, GPs nursing care in that environment as well. So those, and then obviously in the prison setting, we've now got obviously devolved responsibility for health in the prison setting is now health board led. So there's significant involvement, particularly around things like opioid replacement therapy in the prison setting. So there is a lot of those connections, but obviously maybe the point you're making is that there could be an awful lot more. And if we're focusing on a public health approach, then I would argue that there should be, and we'll maybe come on to that later on in terms of how those could be progressed. So
in terms of prisons, and we've heard evidence to the fact that drugs are readily available in prison in Scotland, and I see nodding heads, and what I've never quite understood, and I understand why, because it's easier to manage a prison population rather than having lots of prisoners going through cold turkey and coming off drugs. But do you not think we should be doing more when we have people in custody in prison and they've got a drug problem, rather than just accepting drugs in prison because it's easier to manage the people in that condition? Should we not be doing more to try and address the underlying drug addiction which invariably may have resulted in them being in prison in the first place?
I think I'll maybe let Martin come in, but I think it's a question of where you place the resources, but also in terms of the fact that one of the issues has been, particularly around fatal overdose deaths, is the lack of continuity of care going into prison, and then in prison and then on release. So that's a big issue, and often that's to do with opioid replacement therapy, that people are taken off, potentially when they come into prison, and then actually they have a period of abstinence in prison, but then immediately relapse on release. So that the solutions are not simple in terms of that environment. Obviously, some people may choose, to come off and then attempt to stay off following release. But actually, the problem we have, obviously, is the significant number of fatal overdoses, which has actually reduced in recent times because of better through care issues around naloxone supply, etc. But those issues are challenging, and at the moment I think it's fair to say, and it may help with, for example, that there's new opioid replacement therapy which is long-acting, so using long-acting buprenorphine, which you can have a 2-week or a monthly injection. That may help with some of the logistics in prison of daily supervised dispensing, which actually tends to take up a lot of prison healthcare time that otherwise they might be able to spend on dealing with other issues of prisoners. I don't know whether that... Martin, you wanted to add to that?
So it's really that for us, yes, of course, if someone's in prison, you should do the best you can for them in terms of treatment and so on. But really, I was at a meeting with the Governor of Majesty's Prison, Featherstone, who told us that if you want to end the prison drug problem, stop sending people with drug problems to prison. And he said, you send me your society, people out of society, more of them will come out with a drug problem than go in. And Her Majesty's Chief Inspector of Prisons in England and Wales says 13% of people with a drug problem coming out of prison developed it whilst in prison.
But surely the answer to that is to tackle the drug problem in prison, because from the public's perception, if somebody has committed a crime and the justice system has determined that they should be in prison, and your argument is actually don't send them to prison because they're going to get a greater drug problem as a consequence of that. Surely the answer is to sort out the problem of drugs in Scotland's prisons rather than just stopping people going to prison.
So it's twofold. First of all, they did a programme piloting 10 recovery wings in England and Wales and prisons, and they found that 9 of those 10 still had drug problems in them, even though they were meant to be drug-free. So it's an issue of practicality, but it's also that what you see by the time you get people to this point has been a ratcheting up of the criminal offences that has led to them ending up in prison. And what we'd be much keener on is actually looking at systems like the diversion models, which I know some of our policing colleagues will be talking about later, that look at ways to get people to engage with treatment earlier so they never reach that point in the first place. And that's one of the powerful things about drug consumption rooms. Yes, they save lives. The latest evidence out from British Columbia this month, which you won't have seen yet, 230 lives saved in a 20-month period in British Columbia, similar population to Scotland, just from their drug consumption rooms. But the main thing as well is they're engaging people in treatment in a population that is really difficult to engage as well. So even if those drug consumption rooms were engaging 1 in 4 people, that's brilliant, frankly.
And
yes, I think the question absolutely focuses on why the drugs war has failed. Prisons are secure places. My understanding of most of them is it's 4 walls, 1 door, 1 way in and 1 way out. Every prison in the world is a place where you can get drugs. Everyone knows that. And if you hold to the belief that if you put people away in a secure room it's not going to happen, then that's just not reality. The people who run the drugs markets are criminals. They are clever, adaptive, and innovative people. They do their research, they do research into supply and distribution and costs and all the rest of it. And they have many, many ways of getting drugs into prison. So the easiest way is to corrupt a member of the staff. If you have someone in the prison service who, just for example, is on £20,000 a year, and you give them a brown envelope with 15 grand in it, they are yours for the rest of their service. They will do exactly what you tell them to do because you have control over them. You can blackmail them to do whatever you want. Now, if you cannot keep drugs out of 4 walls and a single door in a prison, how do you expect to keep them out of the general population when there are no walls and no doors the same as there are in a prison? What we are currently doing by prohibiting it does not work. So we need to change what we are doing. We need to take it away from the criminals and bring it back under control.
I think you've irked a lot of attention on the committee, so I think 4 people we want to come in. This is what the fair before we move on to Mr Shepherd, and we'll start with Paul Masterton.
Yeah, just sidetrack back to the start of the question. Obviously, the Specialist Drugs Court in Glasgow's been fairly successful. I mean, do you think there's grounds for seeing more of those types of approaches around, well, not just Scotland, but even the different justice systems around the United Kingdom?
Say that again. Has it been more successful?
Yeah, I mean, do you think that the success of the Glasgow Drugs Court merits looking at rolling out similar models more widely?
Well, I think the specialist drug courts. I'm not familiar with the detailed costings, but my sense would be the specialist drug court is more expensive than running the drug treatment and testing orders. So it's probably when you've only got the volume of cases that it would merit that. So I think it's probably better to look at the drug treatment and testing orders rather than the drug courts. That they've been almost like become a thing that I suppose in terms of being highlighted as such wonderful practice, particularly from the US and things. I would be more in favour of actually concentrating on the drug treatment and testing orders than necessarily the specialist courts. In terms of comparison to other jurisdictions, as I said, that they are successful in their own terms. I'd have to go and look at the comparative data compared to other countries. But I think there is a risk, I think, as my colleagues will probably allude to, in terms of concentrating too heavily on the those interventions as opposed to trying to do more to actually keep people out.
Coming in, I remember when drug courts was announced, must be about 15 years ago now. It was a big initiative that was going to make a significant difference. Has it been the case?
I'm not specifically with Scotland, I'm afraid, but there's been some research just out looking at drug courts more widely around the world. And in Ireland, they've had them for 10 years, one in Dublin for a decade. And there, the gold standard of people remaining abstinent from that, they got 37 people over 10 years. And most of those, the conclusion was, were actually those whose lives were fairly stable relatively. They had the social support networks anyway to assist them that could probably have been helped in other ways. So if you're actually looking at a model to help those with the most chaotic lifestyles, that evidence suggests drug courts are not the way to go.
Okay, thank you.
But if I can just add to that, though, obviously
Briefly.
the Scottish Drug Court is not focused on abstinence, nor are the drug treatment and testing orders. They're focused on compliance with the court order.
The treatment orders, are there stats in terms of breaches?
Yes.
So do we know, you talked a lot about continuity of support.
Mm-hmm.
Are you guys all satisfied that when someone is put onto these treatment orders, the funding and the resources are there in terms of continuing to support someone to continue to comply with that order?
Certainly, when the DTO started, the funding was ring-fenced and very closely monitored by Scottish Executive, Scottish Government. That is less so now, so I think there is some maybe difference in terms of how they operate in different parts of Scotland because of the particularly local authority element of funding as part of those. So I don't think they're as coherent as they once were in terms of a similar model operating in every jurisdiction of Scotland.
So then the success of those orders then isn't intrinsic to the order themselves, it's dependent on the resource being followed up to continue to support that person, and what you're saying is that's patchy around Scotland.
And for example, there are significant numbers of orders in Edinburgh, which are far greater than anywhere else in Scotland, so it's being used disproportionately in Edinburgh compared to elsewhere.
And is there a concern then that the reason they're being used so disproportionately is to keep people out of prison, to manage that issue, but without actually having the resources in place to properly support that individual on the journey that they need to end up back in the criminal justice system anyway? No, I don't think so. I think it's probably other areas maybe underusing those orders, so more people are going into prison that could otherwise be placed on those high intervention.
Thank you. I know we've got a number of interventions. Yeah, Jed Killen there.
I think actually Mr Duffy anticipated my question. I was going to follow on from what Mr Lamont was saying, and this idea that we have to deal with this issue as it is and not as we would like it to be. Is there any example of any prison anywhere in the world where they've managed to effectively control the flow of drugs into prison, and what have they done differently that we were doing here?
The only prison area where I understand that it's been slightly reduced is in the Philippines, and it's another prime example of the war on drugs not working. As you'll probably be aware, in the Philippines they have a fairly the guy in charge has got a single view about drugs and drug users and drug dealers, and that's a 9mm bullet in the back of the head. Over 5,000 people have been killed there in the past 2 years, and the prisons are absolutely full. And because they're full, the people inside are not getting access to the same amount of drugs. But the drug use outside the prisons, despite the deaths, despite the very rigid enforcement, hasn't changed, and they've actually said it hasn't changed. So no, there isn't a prison that I'm aware of anywhere where you can't go in and get drugs.
Okay, David Duckett.
Mr Powell, you said something earlier about drug consumption rooms in Canada, and you said that they've been shown to save 250 lives. Given that a lot of the evidence we've received shows a wide range of complex factors that contribute to why people get into drugs in the first place, why people develop problem drug use, can you say a bit more about how can you measure the effect of drug consumption rooms in particular having saved that 250 lives? What's the direct causation, not correlation, but causation?
So the research they've done there is actually looking at the combination of OST, methadone, etc., the use of naloxone and the use of drug consumption rooms, and how the three interact with each other and how they changed. British Columbia declared a public health emergency, something that we feel Scotland should do. We feel that
They declared what, sorry?
A public health emergency
Right.
in 2016.
Another emergency.
And then introduced a range of these measures and stepped them up. And that's something we would like the Westminster government to do, to declare a health emergency and lay special powers to allow Scotland to do some of these things. But in terms of this specific research, it's looking at the interaction of those three, and actually the numbers of lives saved by the drug consumption rooms when taken in combination with those others is higher.
Right.
That's them isolating the drug consumption room element from that. And it's actually a range, 160 to 320 to 250.
So you've taken this sort of mid-range. But so given that there's several different interventions have been made, how do you know that drug consumption rooms on their own have had any effect?
It's an incredibly complicated statistical analysis that they've done that frankly is a bit above my pay grade in terms of the academic mathematics involved with it, but they're very confident, and it's been peer reviewed, published, looked at by other scientists and mathematicians who understand these measures better than I.
So speaking as a recovering scientist myself, could we get that presented to the committee so we can have a look at that? I'm genuinely interested in how you come to that conclusion. I'd like to be able to review that.
I think, though, the point obviously with British Columbia is that they have drug consumption rooms across the state of British Columbia and not in one location. And that's where it's, we'll come on to that. But obviously one drug consumption room is not going to have an impact like that.
But just to give you the background to my question, as a former chemist, when you carry out an experiment, you can only do one change at a time to really qualify that result. If you make multiple changes, you can't really tell which change you've made has actually achieved the result, regardless of how positive that result is. So.
I have to tell you, David,
okay, well, maybe
we've also had,
let's take it off.
On that, we also had the evidence from Dr. Pierderche at our last meeting, who was saying something similar, just about some of the impacts and statistics. So maybe we could get concise evidence on that, and anything you could do to help us with it is good, because this has been a debate that we've been having within the committee just about some of the analysis and evidence. Christine Jarkin.
Thank you very much. I was just going to ask again, I think, Mr Duffy, you possibly anticipated my answer, but you were talking about the reality of the situation in prisons with drugs, and the easiest way to get in is to corrupt a member of staff, give them a brown envelope with cash in it. If we were to decriminalise drugs, would it be fair to say that then would remove the incentive of paying or corrupting prison staff if it wasn't actually a crime and we controlled it better and it was regulated and we regulated it in prisons, for example? You then take the criminal element out of it and you begin, it's the same argument if you like, in prisons as out. You begin to take control of the situation and crack it and change it from being a problem that's completely out of control to one that you're managing, and you're taking out the criminal element.
If you take the criminality out of it, perhaps the best way I could example that is if you may be aware that in 2014, the state of Colorado in the United States of America decriminalised cannabis for personal and recreational use. There were many people at that time who said, the sky will fall in, this will become a drug capital of America, and that didn't happen. Last year, the state of Colorado sold $1 billion worth of recreational and medicinal cannabis. From that $1 billion of sale, $200 million went in tax to the local authorities. Now that's $200 million that was used for schools, hospitals, education. In fact, I spoke to two people from Colorado last week who said their roads have never been so well maintained and their streets have never been so clean. And people hear that argument and think that's a really good thing, and I can't deny that. But what I try and get people to do is look beyond the 200 million to the other 800 million, that 1,000 million in total. That was $1,000 million that didn't go to criminals, that didn't go to the black economy, that didn't fund people trafficking, child prostitution, counterfeiting, all those other things that organised crime do. Now that is not a bad thing if that stopped going to them. To take it back to the prisons, yes, if you legalised it, you have to regulate it and you have to control it. You have to put in place systems and regulations, as they do in Canada, that allow people to grow it in their own homes under licence, people to sell it under licence, so that you know what it is you're getting. It does exactly what it says on the tin. You know the purity, the strength, the effect and your responsibilities. Now, if you're going to do that in the general public, yes, you could extend it to people in prison. We've stopped them smoking in prison. We could do other things as well.
I'm conscious of the time now. I'm really keen to move on, but Ross has raised his hand. So quick one, Ross, if you don't mind. Then
yeah, sure. Thank you very much, Chair. I just wanted to ask a question round about taking the criminality out of it, as you've mentioned. Because, as I've always said in the committee, that as long as there's a demand, there's a supply, because people want to make profit off of addiction. So take it away from the criminals to hand to, whether it's corporations or companies or whatever, to do so. But we already find that in alcohol, for example, the prevalence of illicit alcohol, particularly across Central, Latin America and Africa, actually outstrips the legal trade. And the WHO said that illegally and informally produced alcohol made up an average about 25% of alcohol consumed worldwide. Then in tobacco, over 450 billion cigarettes are sold illegally across the global tobacco market. So if you hand the profits, like I said, to corporations, you will still have a black market, because no doubt they want to make a profit. There'll be those that don't want to pay it. And even in relation to prisons, you'll have those operating in the criminal world who still want to... I can't see how you take the criminality out of it, even if you legalise it. So it'd be I mean, do you agree that there would still be an illicit black market in drugs, even if we were to legalise it?
I think at the moment you have a drugs market that is completely and utterly unregulated. It's controlled by criminals, by gangs of people who use violence, extortion and all sorts of things to get their way and make their money that they pay no tax and nothing on. If you were to bring in a legalised, regulated, controlled system, you would get a degree of control over it. So if you were to say to me, we'll put in a legal system which will give you 75% control over a system over which you currently have no control at all, I'd bite your hand off for it. There is no silver bullet to take this whole thing away and make it disappear and go into the past. There is always going to be a market in illegal tobacco and illegal alcohol, and there will always be a market in illegal drugs. But if you can take that market down from what is currently 100% of that market down to 25 or 15 or 10%, then that has got to be an improvement.
Thank you. Well, Mr Shepherd's been very patient, so Tommy Shepherd.
Good morning. So I want to come back and widen the focus on this whole relationship between what people are trying to do about the problem and the legal framework for the supply, distribution and use of drugs, and the fact that we've got public agencies at all levels in Scotland trying to cope with what is a major problem, but the legal framework is in its entirety reserved to this place. Could you tell us how the current legal framework impacts upon the ability of criminal justice, health and social care agencies to do something about the problem? My second question is, because we've had some tentative suggestions that even within the existing framework, without changing the law, there is more that could be done and ought to be being done. If you could talk about that as well. And then finally, this is the opportunity where I would invite you to comment on whether and how you would like to see the legal framework changed.
First of all, in terms of what more could be done at the moment, the police use recorded police warnings for cannabis, and there are about 6,000 of them issued in the last year I looked at. We would like to see those expanded to include all other drugs. Now, I understand from police contacts that the concern was that it's easy to identify cannabis, less easy to identify other drugs. But actually, if you expand it to all other drugs, then it doesn't matter so much what that white powder is that you found. And then you could link that to a diversion scheme, such as I know you're going to hear about from Thames Valley Police, about referring people for an assessment for treatment or other things as well. So that's one of the things that we'd very much like to see done north of the border.
And that can be done within the existing law? There's no legal problem with that?
It can. I mean, just to add to that, though, I think it does need clarity around amounts that people can have for possession. And we don't obviously have that with cannabis recorded warnings at the moment. There's no clarity around how much you can possess. And it would only result in a...
I know colleagues behind us will tell you about how they manage that issue within their diversion schemes. Yeah. In terms of other things that we'd like to see changing in terms of the Misuse of Drugs Act would be very specifically in the short term to allow drug consumption rooms to be piloted, so the law change around that. It would be to allow de jure decriminalisation like Portugal, because there are many benefits that are missing with diversion schemes that you can deliver with full decriminalisation. and ultimately to allow the Scotland, and well, we'd ideally like the rest of the UK as well, but Scotland to explore some of these other models of legal regulation to see whether they might be beneficial in a really cautious, piloted way where you can roll it back if it's not working and so on. So no big bangs, no sudden shocks to the system, very careful, cautious, evidence-based approach.
So do you accept the argument that a drug consumption room in Glasgow cannot happen unless the law is changed here?
I think in practical terms it can't. Because, again, talking to some of the people who would actually implement it, is that for them to put their staff in a potential position of jeopardy, of legal jeopardy, is very challenging for them, even if they think that it's only a slightly grey area. If you're the NHS and you're being asked to put in money to fund something like this, it's very challenging. So I think there's probably more to be done in terms of moving the debate onwards, but just in practical terms.
If I could add to that, though, we certainly do have a frustration that the Misuse of Drugs Act is used as the means for delaying responses. So our view, and we, obviously that was the view of Glasgow as well when they put forward was that the Lord Advocate could issue a letter of comfort, as he's done in other related areas, like for naloxone, for example. And I know the Lord Advocate and the Minister will be speaking to you next week, I think. So I think, that is a frustration that we have, is that, there are delays in that, and I would encourage the Scottish Government to be braver in that regard, and progress that. Similarly with, for example, things like drug checking, which has taken place in other parts of the UK. For example, at festivals, there's drug checking undertaken by the Loop, and also there's the Wedanos programme in Wales that does drug checking and feeding the analysis back to users. So that's again an area where Scotland has not progressed that and could do within the existing legislation. So I think, and similarly as Martin says, with extending the police recorded warning, I think we could do all of that in Scotland within the existing framework. So that is basically moving towards a model of decriminalisation, and we should be brave enough to do that, because it would help, and maybe in line with I know you're going to visit Portugal, I think, later on. I think in line with the Portuguese model, which is one of social inclusion fundamentally. So it's not just about decriminalisation, it's about all of those other issues around better access to treatment, better quality of treatment, looking at housing, employability, welfare benefits, etc., etc. So it's quite a profound shift, and that's what we would be looking for in terms of decriminalisation as part of that, including drug consumption rooms and heroin-assisted treatment as part of that.
Really quickly, and you divert the money you save to fund these things, so you end up with more money going in, and it's that critical. Decriminalisation is a critical enabler of change.
Mr. Duffy, you want to come in? No, it's okay. Tommy.
Sure. Well, can I have a supplementary to this? And so one of the things we've actually not talked about hardly at all in this inquiry so far is cannabis. To be honest, everyone just sort of seems to accept that that's a different category. Yet, of course, it's just as illegal to use cannabis as it is illegal to use heroin. So, I don't think. I mean, I detect there's probably not an appetite in this place for a radical change in the 71 legislation to the extent that I guess you guys would like to see. But it may be possible to get some movement on the recreational use of cannabis over the next few years, bringing it into line with the development of the States, Canada, elsewhere. Can you, given that, I mean, I'm not aware that any of these fatal overdoses, for example, any of the drug deaths relate to cannabis, how would decriminalisation or legalisation of cannabis in this country, how would that have any impact at all on the deaths that come from opiate-based drugs?
I think you're absolutely right. There's never been, as far as I'm aware, a death certificate in relation to a drug death that says cannabis as a cause of death. We have a tremendous number of cannabis users socially, medically, recreationally. If you go across and look at Colorado, where they have legalised medicinal and recreational cannabis, I've already alluded to the income that they receive from that in tax. and what they can do with that in the way of education and treatment. There's also a fairly substantial body of evidence now that in Colorado and the other 11 states in America would have legalised the possession and use of cannabis, that people who were previously addicted to opioids are using cannabis to come off that addiction. So there is a benefit there in as much as they can wean themselves off the opioids with the cannabis. Some people would say it's a lesser of two evils. No, I think if it's something that helps them to be better people and to live better lives, then it should be supported. What we're looking about here is, the thing to get our heads around about is, this is about saving people's lives. This is about people who have addictions and problems that are dying, and dying now in Scotland in their thousands. And we sit here and we talk about it and we go round the edges. We need to do something positive to start saving lives. Lives are being saved all over the world. In Canada and America, where they've legalised it in certain states, there aren't the same number of fatalities. When you see what they've done in Portugal and what they've done in Switzerland, there aren't the same number of people dying. But then you come to Scotland and the United Kingdom, and in Scotland we are dying in our thousands, and we're not doing anything about it.
Just very specifically on the cannabis, the reason that a major driver for the Netherlands introducing their cannabis cafes was to separate out the cannabis markets from the other drugs, so that you wouldn't get offered any other drug when you were in there and you go and purchase. So when young people went in to buy, they weren't offered opiates or anything else. So that would be one potential way where if you manage a cannabis market here in the UK to separate it out, you could in the longer term help with those kind of issues.
So I mean, are you suggesting that because cannabis is illegal, if the 500,000 users in Scotland want to use it, they have to come into contact with illegal supply, and that then puts them into a place where they're more likely to use other drugs? Is that the argument? They're more likely to be offered them. Beg pardon?
They're more likely to be offered other drugs.
Right.
They might well be offered other drugs, but it doesn't necessarily lead that people who smoke cannabis will go on to use other drugs.
Yeah.
That's like saying people who drink beer are eventually going to drink vodka because it's much more powerful and gives you a hit much quicker. It's about choice.
No, I get that. I'm just wondering that if there was a change in the law in relation to cannabis, whether it would help this problem of people dying from overdoses of heroin or other.
Well, I think the recorded warnings, we've already seen a movement in that direction, but I think our argument would be that we should decriminalise possession of all drugs rather than just focus on cannabis, and particularly because the arguments around like the Portuguese model, one of social inclusion, bringing people back in, sending a message that people are part of society and they should be the problem should be normalised as opposed to I remember the US talked about denormalisation and the Dutch talked about normalisation. So I think it's about normalisation, and social inclusion is the key to what we should be trying to achieve.
Okay. Thank you. Ross Thompson.
Thank you very much. I just wanted to come in because I know Colorado has been mentioned a couple of times. I did have the opportunity to visit Colorado and speak to politicians in Denver. And what I noticed actually was on the streets was I saw a lot of people with mental health problems on the streets who were using cannabis. And a study just put out there that was conducted back in 2016 said that there had been a threefold increase in hospital emergency rooms receiving people who had been consuming cannabis, and those who were consuming cannabis were 33 times more likely to end up in A&E than before it had been legalised. So do you not see that there is potentially, yes, you take the criminality out of the issue, but it can lead to other issues around about mental health?
Specifically on that, one of the confounding factors there is the fact because it was illegal, people weren't going into A&E because they didn't want to admit that they've been taking drugs. So you have to be very cautious with those kinds of statistics, and really what we need to be looking at is more longer term, looking at the trends rather than anything that happens in the first couple of years when people get used to the laws. And if you're concerned about the problems of using, for example, high strength cannabis, you can only manage that within a regulated market. So say we advise the Uruguayan government on their model. What they've done down there is you have an anonymised registration process before you can access. You get it from the pharmacy and they cap the strength at 10% THC that you can get through there. Those are the kind of measures that are only possible in a regulated market.
I understand that. I mean, I I was part of a campaign to ban the sale of legal highs in Aberdeen, and that was something we could walk into a shop and buy, and some of them were cannabinoid style substances. And speaking as part of that campaign, and speaking to those in Forster Hill and Aberdeen, they were saying that they actually had people coming in through their doors in A&E who had worse injuries having taken legal highs than they would have if they'd actually been in a car accident. They said it was horrendous. Now that was strong cannabinoid style substances that were free and available but have now been banned. So I'm still very concerned about the wider health impact if we look at, because we've had something that's legal and we've just made it illegal, and now we're looking at actually taking a reverse step.
Yeah, with that, for example, the Netherlands has no problem with synthetic cannabinoids at all to speak of, because it never arose because people were able to access cannabis. And what we've done through criminalising cannabis here is actually drive people to use these legal highs. They're no longer legal highs. But for us, actually the criminalisation of them en masse, whilst it's reduced the very visible access in head shops and so on, you've compounded the problem in places like prisons, as we know. And again, I met Prison Officers Association, the Deputy Secretary General, who's aghast at the state of this issue, and they're really keen to look at alternatives, again, that mean fewer people end up in prison, and that means starting way back down the chain in terms of providing the treatment and support so people never reach that point, and when they do encounter police, they're bounced elsewhere.
So the time, I've only got a few minutes left, and I'm going to make sure everybody gets in, and it's Daniel Rowley.
We've talked a lot about international examples. Just wondering if there's any really good examples, evidence-based, of countries where they've went for the decriminalisation approach, and if there's evidence to show it's had a positive impact on reducing problem drug use and drug deaths ultimately.
Well, obviously the Portuguese example is clear, both in terms of drug-related deaths, but also in terms of HIV as well. And obviously we haven't mentioned that, although I'm sure it's been mentioned earlier in your evidence, that Glasgow has a current outbreak of HIV among street injectors. And the alarming thing about that is for example, Athens had a similar outbreak at the time of severe austerity, and they managed to get their outbreak under control more quickly than Glasgow has. So we've got those issues of real concern. I'm not saying it can all be dealt with by decriminalisation, but it is the wider package of measures which I'm particularly keen to link to decriminalisation, rather than seeing decriminalisation as the panacea on its own. And obviously Norway recently, for example, has just developed a whole strategy around fatal overdose deaths, and that again is also linked to a process of decriminalisation. So many countries have linked those two issues together to make wider progress. But for me, it's about the social inclusion aspect of that, and the message that sends to people who are highly stigmatised and marginalised, that actually we care about them, and actually we want to give you the appropriate level of support you need.
Concrete example, Czech Republic. So Czech Republic only criminalised drug use in 2000 to try and clamp down on drugs. After 10 years, they did a cost-benefit analysis, and they found that the criminalisation had made things worse, had increased social costs and harms, and hadn't reduced use. So they actually decriminalised again at that point in order to do these things and divert some of the money into treatment.
We were looking for examples of nations that had perhaps decriminalised or taken a more liberal approach to drug use, and I think Denmark came up as an example, and I think Norway, wasn't it, David, that was suggested we look at that. Is there a clear example or evidence that nations who have gone down a path of more liberalisation, perhaps decriminalisation, have decided it doesn't work, and then tried to reverse that and made it much more difficult or criminalising again?
Well, I suppose the Czech Republic was an example that went one way, went the other, and then went back again.
What about Denmark? Denmark, there was we've got evidence that there's areas of Copenhagen, for example, where there's issues for some of the local population. Is there anything that you've observed which should concern us?
I think you have to do it well. is the core example on this, and there are a lot of detail around the implementation where you can get it wrong. Things like thresholds, how much you set people allowed to take, whether you do put the money in to do other things, and we can send you links to a lot of different countries with comparators about this. But the core issue here is the fundamentals work. It only ever goes a bit wrong when you don't get the detail right in terms of looking at this holistically. But there are no terrible examples where you point at that and say that means decriminalisation doesn't work. You might say that didn't work because you didn't do this.
David, did you want?
So the particular example of the Netherlands, which famously with the brown cafes and I remember visiting Amsterdam once where there were still people coming up to you in the street, like literally opening up their coats and a range of various things. But sorry,
Get that in Glasgow.
yeah, not so much in Amsterdam these days, though I've noticed. Well, I visit Amsterdam a lot. There's excellent art galleries and other attractions are available. But my question was going to be, why did the authorities in the Netherlands pull back from their liberalised policy in the first place? And did that succeed, or did that have the desired effect?
So we've written a briefing on this. So there was concern about people coming in from France in particular into some of the smaller towns at the edge, and you get lots of tourists and people were uncomfortable with that. So they tried to introduce a residents-only permit for sales to exclude that. Some of the big cities like Amsterdam actually objected because tourism is a big industry and worth it, just the same as your distilleries in Scotland and so on. So in the end, what they went with was to give the municipalities the power to do that if they want. So some have no cannabis cafes, some have residents-only stuff still, most didn't. And the places that did actually introduce them, they did reintroduce the street markets again. It was being sold on the streets again. So some of those were reversed as well. But again, this is only possible if you've got a regulated market. Same as Uruguay has a residents-only law for their cannabis as well. So it's actually an argument for regulation as far as we're concerned.
Okay, thanks.
Tommy Shepherd.
This leads me on to a more general question, really, which is, if we were minded to argue for a change in the law, could you comment on what the potential risks and benefits are of decriminalisation versus a legalisation approach? Perhaps drawing on international examples of where things have worked best. What do you think would work for the UK and for Scotland?
I think what would work for Scotland is if, for the UK and Scotland, is if we were big enough and brave enough to realise that what we're currently doing is not working. And the biggest danger to us is that we continue to sit and wring our hands and say, this is terrible, we must do something about it, and not actually do anything. We need to realise that what we're doing is not working, so we need to change it. And the change that we advocate is that you legalise, regulate and control it, you take it away from the criminals. The danger there is that this has already been alluded to, is that we don't do it properly, that we do it in bits and pieces, and we allow big pharma to take over huge swathes of it, and we don't allow the cottage industry, as they call it, when people do their own production and use. That's the big danger there. People have to get the understanding of the difference between decriminalisation and legalisation. Decriminalisation is when we make it no longer a crime. Legalisation comes with the other two words, regulation and control. It's not a free-for-all. You have to put in place systems that allow, for instance, the alcohol industry. Ewan Harry has got a very good book out called Chasing the Scream, and he gives a beautiful example of, in relation to the alcohol industry, the head of tenants doesn't go around and beat up the head of Carlsberg in order to get a bigger share of the market. And they don't do that because they have licences to lose, they have markets to lose, and they're regulated and controlled. We do that with alcohol, we do that with tobacco, we do it with gambling, we do it with vehicles, all things that people can get addicted to and cause lots of deaths in the country. Why do we think that continuing to prohibit drugs is going to be a different game changer? We need to realise that the prohibition doesn't work. The only place where they've tried prohibition on any great scale, as I'm sure everybody remembers, is the United States of America. And the only thing that people remember from that nowadays is Al Capone. And how did Al Capone go to jail? Not for drug offences. Al Capone went to jail because he didn't pay his taxes. And that's the huge amount of money that could be brought into the government and into the country. And the cannabis industry in the UK alone is $6 billion, £6 billion a year. Take the tax take on that, what could you do with that? along with the savings from police time, court time, hospital time and the rest of it. It calls on us to be brave and forward-looking. We need to do that.
I would say agree entirely with what Jim has said. There's a process about this as well, though. You could decriminalise drugs given the power very rapidly. We could do that. Then it's about sequencing. So do what we know works already. Look at cannabis regulation where it's in place and is working. By the time this actually was done, we'd have 2 or 3 more years of evidence on that. Look at expanding heroin-assisted treatment significantly. In the cohort who that's relevant for, about 10%, use around half of all the heroin, so you can take half the heroin market away immediately from that. Then do piloting of other measures in a careful, cautious way, learning from the lessons from alcohol and tobacco, pharmaceuticals, etc., and opt for more strict than you think you need at first, because it's much easier to ease back on those controls. So complete bans on advertising, all those kind of measures.
Thank you.
And we've got a whole book on this if anyone wants to read.
Anything you've got, please send on. Hugh Gaffney.
Yeah, you might have answered it, Jim, but you spoke there about it. My interest is the gangs. You know, once a gangmaster takes control, and once he's wiped out, once you've done your job, you've wiped him out, somebody else steps up to the mark. So we've no control over it. And I think what you just described there was actually a good way of putting it. The police time, all the time wasted. Our kids are now dying in the street, getting murdered, stabbed, because they're running with drugs. That's the way I see it. So we have to look at this wholeheartedly. And I think your assumption just 2 minutes ago maybe summed it up. But we do need to look at this properly and maybe have to put the licence on it and take away the power from the gangmasters.
Without stealing the thunder from the people who will follow me onto this table, the 164 organised crime groups in Scotland, 2/3 of them are involved in drug trafficking.
Yeah.
And I've quite often, when I go around the country and talk to people about this, they'll say to you, well, if they weren't doing drugs, they'd be doing something else. To which I say, good, let's make them work for their money, because at the moment they don't have to. At the moment everything is set up and focused around drugs and the constant flow of money that comes in. Nothing would be better than to cut that off from them and make them do something else.
Yeah.
Thank you.
I think it's
Quickly.
Because of the right point, do you have any evidence, yourself in particular, Mr. Duffy, that of what other crimes previous drug dealers get into when we take that opportunity away from them?
I don't.
No, okay. It's maybe a question for the next panel.
We haven't had the situation yet where we've taken that away from them. But knowing that they are resourceful and educated and clever people, they will have something else to do.
But
unfortunately,
for us, that isn't an argument. In the same way that the police generally tell us to lock our windows, stop burglars coming in. They wouldn't say leave your windows open because the burglars might go and do something else.
Thank you for that. Christine Jardine.
Very much. Mr. Duffy, you've said quite clearly that decriminalisation has to go hand in hand with tighter regulation, and you've touched on some of this already. But are there specific regulatory changes you think we need to make right away for it to be effective?
To do something right away and to become effective is extremely difficult, because we are governed not by the rules that are set in this place, but by the United Nations and their attitude towards drugs. And that attitude is heavily influenced by the United States of America. There is a huge lobby group within the United States of America not to have any change. There are a huge number of lobbyists who work for the private prisons who are actively campaigning for stronger drug laws, longer prison sentences and more prisons, because they're run privately and they make almost as much money out of the prisoners as the drug lords are making out of the dope. So there's a fundamental change that needs to happen there, which is a very difficult thing to influence. However, I struggle to see why we should accept the level of deaths in this country from the drugs market and say we can't do anything about it because of what they've said. Yeah. Let's do it.
Going back to the criminal or the crime element of it again, would it be unrealistic to say that there are a lot of crimes which are the consequence of drug use, which the rates of those crimes might fall if we decriminalised or legalised drugs in a way that it was regulated, because the consequential effect of taking the gangs out of it is that the people who wanted the drugs would not be involved in crime. And if you like, there's a wider picture. It's like we think all the time about drugs and crime, but if you throw the pebble into the stream of deregulating it, there's a whole lot of ripples that go out and affect other crimes, and would make give the criminal justice system, if you like, an easier burden to deal with by reducing the overall level of crime.
If you take, for example, Switzerland, where they made the very brave decision a number of years ago to do the heroin treatment centres, and they gave the heroin addicts heroin. The crime rate at that time was horrendous. There were parts of the city that people couldn't go into. They put the scheme in place, and crime fell by 80%. And all the time, they went back to the people 10 years later and said, do you want to continue with this? And the people of Switzerland said, yeah, you're absolutely right, we want to continue with this because it works. And so far as I'm aware, there hasn't been a drug death from a heroin overdose among any of the people who are on the heroin treatment programme.
So just to simplify and summarise it, if we tackle drugs problems properly and look at a solution, we could be also looking at a solution in a lot of other areas as a consequence of dealing properly with crime, with drugs, rather than just going for a straight-out prohibition, which doesn't work.
It doesn't work.
Thank you.
Just lastly, there's no chance of any of this happening, is there? Because, like we heard the last statement from the Home Secretary, because of his childhood experience in his neighbourhood, he was not of the view to doing anything about our drugs laws. And I'm just looking at a statement from the current Home Secretary, yes, and I'm just... The statement from the Home Office, the Home Office refused to come and give us evidence at this, which we find absolutely appalling that they're not prepared to come here and defend their position when it comes to this. So we're still trying to encourage them to come. But the only statement that we see from the Home Office is that legalising cannabis would send the wrong message to the vast majority of people who do not take drugs. Now, this seems to be government policy. This seems to be their approach to these loads of drugs deaths, all the issues about criminality, drugs gangs and everything else. We've got no chance of this ever happening, have we? This is the current view of the Home Office.
But I think, as we've said, within this, the existing framework, we can deliver decriminalisation in Scotland through recorded warnings. So we can do that. We're also developing heroin-assisted treatment. That could be rolled out more widely. And I think maybe to add to that point, Switzerland, obviously, it's not just heroin-assisted treatments, it's a range of other treatments and options for people as well. And they have a very high proportion of people with drug problems in treatment, which we don't. We have, it's potentially, I think you've heard that figure of, only 40% in treatment. And the other issue we have is that we have very poor retention rates in many parts of Scotland for people in treatment. So all of the issues of people going into prison, dropping out of services, etc.
And yet, of course, there's things, but when you're up against a government whose approach is sending wrong messages.
But my argument is that we've got a crisis in Scotland, and we need to do those things now. We shouldn't wait for the Home Secretary in Westminster. We should do them now. We need to do them now.
I know, Christy, why won't they accept some of the evidence that's coming from international examples?
Interestingly, they do accept it, but in their own research, the Home Office has produced reports that accept the evidence that criminalising people doesn't reduce use. They accept the evidence that drug consumption rooms work. So it's not that they don't accept the evidence, it's that they stick with some of these old ideological ideas about sending messages, when actually the criminal justice system is historically an appalling way to try to send health messages, particularly to young people. It doesn't work. If you actually want to send messages to young people, you need to be engaging with them and talking to them. But I'm actually much more optimistic. We have seen this government shift quietly in ways that I wouldn't have expected. They aren't trying to stop diversion schemes. They licensed a drug safety testing clinic in Weston-super-Mare. They are actually supportive of heroin-assisted treatment, even though they won't fund it, which is they really should do. So, and also we've seen with many issues, no, and then all of a sudden it changes, yes. Well, and we just need to keep pushing.
Christine Jack.
Thank you very much. Just on that point, I wonder the extent to which you're here giving us evidence on specific questions, but in the hope that you can influence us, or that we can see the evidence that you present, so that perhaps later in this government, or maybe even a different government, because we don't always have the same government, might see the evidence, and you might find that a different government has a different attitude And only if we listen to the evidence here and we record it, that's the effective way to make change.
And I think there is, if we look back to the 1980s, we've seen incremental change all the way along. You imagine somebody now getting 6 years in prison for 1 gram of heroin. So things have shifted a long way in terms of. So I think the challenge is always that it tends to be incremental change as opposed to more fundamental change.
We're going to have to leave it there, gentlemen, but thank you ever so much. That was a fascinating session and we really much enjoyed your contributions today. I think there's a couple of things that we've asked you for which hopefully you'll be able to provide to the committee. And anything else that you could usefully contribute, please get in touch with us once again. And thank you just now. And can we have our next panel, please? We're all sorted then, yes? Okay. Right, thank you. Thank you very much for joining us today in our inquiry into problem drug use in Scotland. Just for our records, who you are, who you represent, and anything by way of which will have to be a very short statement, given we've got 4 of you here today. So we'll start with you, please.
Thank you. Jason Q from Thames Valley Police. I'm a Detective Chief Inspector and implemented Thames Valley Police's diversion scheme, which is a pre-arrest scheme designed to... Do I need to be worried about that bell?
No, it's just telling us that we've started.
Run outside. Thank you. Which is a pre-arrest diversion scheme which enables everyone found in possession of a controlled drug, regardless of their age or regardless of the type of drug, to receive an initial assessment at the drug service and an education programme which is non-judgmental and provides better outcomes for that individual.
Thank you. I'll just call you Mr. Johnson, if that's okay.
That's
I know
absolutely
you've
fine.
got I'm not even too sure what ACC is, but you could tell us. Assistant Chief Constable.
I'm glad you got that. So I'm Steve Johnson, Assistant Chief Constable. I was the lead for Specialist Crime and Intelligence for Police Scotland for the past 3 years and hold of the drugs strategy portfolio, responsible in the main for targeting organised crime and dealing with counter-terrorism in Scotland.
Thank you.
Morning, my name's Kevin Weir. I'm a Detective Superintendent in Durham Police and I'm the Strategic Lead for the Checkpoint Programme, which offers a 4-month diversion from prosecution if you comply with the issues that you've got and you don't result in any prosecution if you successfully comply.
My name's Alex Stevens. I'm Professor in Criminal Justice at the University of Kent. I recently stepped down as President of the International Society for the Study of Drug Policy. I'm a member of the Advisory Council on the Misuse of Drugs for the UK, and I was the lead author of its report in 2016 on reducing opioid-related deaths in the UK, and also its very recent report on reducing drug-related harms in transitions between custody and community. I should mention that I cannot speak on behalf of the Council because only the Chair can speak on behalf of the Council, but I can speak about the Council as an independent academic. And I should also declare I'm also a Special Advisor to the Health and Social Care Select Committee. I'm also a Special Advisor to the Health and Social Care Select Committee on a similar inquiry that it's running at the moment and will be meeting this afternoon.
Okay, well, 3 very distinguished police officers with us today with vast experience in this particular field. How does criminal justice interventions help us deal with some of these issues that we've heard about today, and how does it help us address some of the appalling drug deaths that we've had in Scotland? Does criminal justice interventions work? We'll start with you, ACC Johnson.
And I suppose I think it's a balance. Clearly, I can give you some statistics. Certainly, I've been in Police Scotland for the past 3 years, and we're not shy of 3,000 drug-related deaths in Scotland. The official statistics, if you like: 2015, 539; 2016, 788; 2017, 903; and 2018. And this is an unofficial statistic. I keep a tally of the drug-related deaths every day. We're going to hit around about 1,067, maybe just break the 1,100 mark once we get past suspected drug deaths. So, since 2015, the figures have doubled in Scotland. And for me, those are not just statistics. I get reported every day the names, the ages and the locations across Scotland. And of the 13 divisions, there isn't a division in Scotland that hasn't seen an increase. And certainly from 2017 to 2018, very, very nearly a 20% increase in drug-related deaths. And I suppose one thing I would want to get across to the committee is probably the sense that's felt by the sort of root and branch officers of what I think they would call the hamster wheel. And that's our custody staff and our operational staff that see people, and it's just a matter of time that they come through the custody door, they get processed through the criminal justice process, they go in through the sheriff's courts, they go into prison. Of those people that come out of prison, 11% of them will die within the first month of having been released, according to the statistics. But the police officers get used to this carousel, you know, this sense of hopelessness and helplessness. Their first duty of every police officer is to preserve life. Of course. And when people don't come back through the doors with that alarming frequency, it's probably because the person's dead. It's not because there's been a successful intervention through the criminal justice process. So that is a sense, if you like, of the foreboding sense within law enforcement. But there is an awful lot of good that we do with partners around diversionary schemes, trying to divert people away from criminal justice, work that we do with young offenders in Polmont, trying to divert them away from organised crime. But overwhelmingly the sense is, for me, dealing with a serious and organised crime group, you know, we've had some successes. There was a question earlier on. From 163 serious and organised crime groups in Scotland, we're down to about 96 now. But actually what's missing, I think, in the criminal justice process is it's seen as supply, importation, almost sort of white-collar sense to the criminality. And the criminality of these organised crime groups, I don't believe, is linked to the harm that's caused to the citizens in Scotland. And it's death on a large scale. I think it's an epidemic scale.
I think we all appreciate just the work that the police service do in terms of trying to keep people safe, and we've seen great examples of that, and some of that's been presented to this committee. But what we're finding difficult to understand is, I mean, we can understand disrupting supply and, you know, going after the big criminals who, you know, are the leaders of organised crime. But does criminalising drug users actually seriously assist them in dealing with the problems? And that's what we need to hear from you, and maybe you could help us with that.
Yeah, sure. I think from our point of view, we obviously look after victims as best we possibly can. But from a point of view of an offender, most of the offenders we meet are vulnerable in some way because they have some issue that attracts them to commit the crime. And what we try to do is work with them to do that. So if we're talking about specifically drugs, we will offer checkpoint schemes, which is our diversion scheme, to people who are low-level suppliers. So they're supplied to the friends in the street. So we make a distinction between sad versus bad, and we have a scale that we use to be able to do that. But actually we try to change their underlying causes of why they commit crime and improve their life chances, so actually they can stop committing crime but actually take a better part in society. So we've developed a scheme which is a 4-month deferred prosecution. They have to admit the offence, or at least we have enough evidence.
I want to come specifically to some of the things that you guys are doing, because we are impressed by some of the things that's been offered by the police service. But I'm just interested in this ideological question. You're police officers, you're the front line in the interface between the criminal justice system. You're not health professionals. You're not experts in addiction disorders.
No.
And maybe you could help us with this, Mr. Q.
Yes.
Why is it you guys that are dealing with this issue and not health professionals, and what do you actively contribute to making this better?
So I can speak from a personal point of view, and I don't want to bring my organisation into any form of disrepute from my own views. So individually, criminalisation doesn't work for simple possession of drugs. And I say that because there's a significant amount of stigma attached to policing. So taking best evidence from Checkpoint and West Midlands Turning Point schemes and Bristol's drugs education programme, all have seen evidence that actually the role of police and the role of capture and punishment has little effect actually on drugs possession. I'm only talking about drugs possession in isolation here. So what is the role of police in drugs possession? And the police aren't punishers. We collect evidence, and as ACC Johnson just mentioned, the primary role of police officers is to prevent harm. And with such significant numbers of drug-related deaths, our role, my role, has turned towards a health-based approach to enable education, no stigma, and the most teachable moment, and there's strong evidence to suggest this, the teachable moment in any interaction with police is that moment on the street. So what can we do to maximise that opportunity when someone comes into contact with police officers there and then on the street?
Okay, thank you. And Professor Stevens, I know you can't speak on behalf of the Advisory Council on the misuse of drugs, but you can speak about it. This committee is having a difficulty about what your formal role is when it comes to government policy. You advise government on the evidence about drugs issues. Would that be correct?
Yes, the Council has a statutory duty under the Misuse of Drugs Act to advise ministers on the reduction of drug-related harms.
And what usually happens to that advice?
If that advice is to tighten control on drugs, is generally accepted. If that advice is to loosen control on drugs, is generally refused.
It's next to useless then, given the evidence that we've heard about the fact that drug consumption rooms work internationally, that decriminalisation seems to make...
I would strongly dispute that the Council is next to useless.
The government knows this evidence, though.
The government doesn't always know the evidence. We are distillers of the evidence.
Isn't that your job to give it to them?
We do give it to them, yes, and it's the government's prerogative to refuse or accept it. Sometimes they accept it. So, for example, when we recommended that naloxone should be made more available in 2013, it was made more available, and that's probably saved people's lives. In 1988, when we advised the government that it was more important to keep people alive than it was to punish them for using drugs, the government accepted that advice, and we had to create a harm reduction system that was the envy of the world and saved loads of people's lives.
So you advise government, based on the evidence that you see and you've acquired, probably some that you've even commissioned, look at international examples, you present that to government. If it's something which suggests a hardening approach to drugs, they tend to accept it. If anything which leads to a more liberal approach, they say, no, we don't like that. It doesn't fit with our general policy of sending a message, which seems to be government policy when it comes to...
Yes, which I think is fascinating, because we've just heard from senior police officers with a wealth of experience that they can no longer toe the government line, which is that we need to criminalise people to send a message to reduce harm. We've heard from these senior police officers that just does not fit with their professional expertise.
Do we not need a better arrangement in this then? Where you spend all this time presenting them with evidence which is then rejected, and then conditions and situations possibly get worse. We've got these drug deaths over here in Scotland. Do we not need to make sure the government can accept the evidence? And
I would much prefer that the government not only accepted the evidence but actually put it into practice. So, for example, in the 2016 report on reducing opioid-related deaths in the UK that the ACMD published, we had several recommendations, and the government formally accepted all of them except the one on drug consumption rooms. So it formally accepted that our recommendation, the most important one, was that investment in opioid substitution treatment therapy of optimal dosage and duration should be maintained. Now, they formally accepted that recommendation. They've since cut the public health budget in England by 25%. We recommended that there be central funding provided for heroin-assisted treatment. They formally accepted that recommendation on the basis that there should be heroin-assisted treatment, but they said it was up to local authorities to provide the heroin-assisted treatment, not acknowledging the fact they've massively cut the amount of money that local authorities have available to provide heroin-assisted treatment. So while they sometimes accept our recommendations in the letter, in the actual practice we don't see that. But that's not for the Council. The Council has no powers to implement policy. All we can do is recommend policies to the government. It is the government's democratic duty and right to decide whether to implement our advice or not.
Yeah. Because the Home Secretary famously said that he wouldn't accept drug consumption rooms because of what he experienced as a child in his locality and neighbourhood. I mean, what do you do when you're confronted with, you present the evidence and the Home Secretary actually turns around and says something like that?
Well, I'm an academic, so I'm not a campaigner, but people are, people on the previous panel, for example, are campaigners who will try and get the evidence accepted and
just lastly from me in the Misuse of Drugs Act 1971 and the categorisations. Are they effective? Are they working, the current categorisations of drugs?
Well, I'll refer you to the report of the Science and Technology Select Committee in 2006, which was titled Making a Hash of It, which was about drug classification, which made the point very strongly that there is not a rational justification for the current classifications of particular substances. I'd also refer you to recommendations of the ACMD that cannabis is in the wrong class. So the ACMD has recommended that cannabis should be in Class C. It's currently in Class B. The ACMD has recommended that ecstasy, MDMA, is in the wrong class. The Council has recommended it should be in Class B. It's currently in Class A. You also phrased the recommendation of the ACMD that CAT should not have been controlled under the Misuse of Drugs Act, but it was controlled under the Misuse of Drugs Act.
I mean, this is just so depressing listening to this, you know. I mean, you're charged with advising government and it's just all absolutely, totally rejected. You know, I mean, what's the point of you?
Because this is public information. We're here in public telling you, as representatives of the public, what the best evidence that available is on what should be done about drugs. That is a valuable public role to play, whether the government accepts it or not.
Okay, right, thank you. David Duckett.
Thank you, Chair. Moving on from the rhetorical questions, can I ask Professor Stevens in particular a question you can possibly answer on your own behalf, if not that of the Council? Can you explain the role of the Advisory Council on the misuse of drugs and what the drugs policy ratchet is?
Yes. So the drugs policy ratchet is a term that I used in a paper that I wrote with Professor Fiona Measham in 2014 to describe this very process by which, if the government is advised to tighten control, it tightens control, but if it is advised to loosen control, it doesn't go the other way. It's a one-way system.
Yeah, ratchets up.
It just ratchets up. And this is partly based on rhetorical commitments to toughness. So this idea the Home Office wants to put forward that it has a tough approach to drugs and that any loosening of control would be in conflict with that tough approach. And so when we recommend that drugs, for example, we recommended recently that pregabalin and gabapentin should be more tightly controlled on the basis there's quite a lot of evidence of harm from those substances, especially in prisons. That was accepted because it was consistent with this message of toughness.
So it sounds like that's consistent with the evidence we've seen from a lot of people based on other legal substances such as alcohol, nicotine. They're already legal. So if you were to add the extra control to those, it would be much more difficult to take it away. Likewise, if you've got illegal substances, it's far more difficult to remove the control than it is to apply control. Is that the same?
In theory,
idea?
in parliamentary process, it's as easy to remove control as it is to tighten control.
But I guess in terms of public opinion and the other things that we as politicians all need to consider,
it's a political question.
It's, yeah, okay. Thank you.
Okay, Tommy Shepherd.
Good morning. So the Advisory Council has previously recommended a number of things, and including, for example, its support for drug consumption rooms, as I understand it. So, you know, the chair's already suggested some of the political ideological statements that the Home Secretary of the day may make in this, but the Home Office as an institution seems to have set its face against change, which, given changes that are happening internationally in this debate, does seem quite remarkable. I mean, can you suggest to us, and I'd be welcome to presume the police officers have contact with the Home Office as well, I'd welcome your reflection as why do you think this resistance to change is so ingrained, or is it? I mean, are we just getting are we just seeing what they want us to see? Is there stuff happening beneath the surface in terms of this debate opening up that perhaps we're not aware of?
Historically, if you go back to the beginning of the British drug control system in the 1910s and 20s, it's always the Home Office that's taken the lead in pushing a social control type of policy onto British drug policy. And so there's always been this balance between medical experts and the Home Office, sometimes with the police and support, but increasingly not so, deciding whether health or criminal justice responses should be in the lead. So the Home Office has an institutional commitment, as you said, to the idea of social control and repression of certain activities being the way forward. I think that's crumbling now because of the evidence is so strong on the other side. And people, for example, 20 years ago, you would not have had senior police officers publicly disputing the Home Office line on how drug policy should be. So I think there is an opportunity now to make some change.
For me, I think we have an ideal opportunity in Scotland. The move from justice to health as an issue in relation to the drug strategy is a huge bonus that we have there. I think the performance regime in the past, so how many different arrests for different class and different type, how many custodial, how many sentences, very much sort of numeric, valueless type of performance statistics. And that's against the backdrop of increasing deaths. And as Jason and Kevin have said, you know, many of the people that we see are vulnerable without taking the drugs. They have other complex issues happening in their lives. The drugs potentially are part of the management of that or part of symptomatic of that. And it feels very punitive. I can't answer for the Home Office. I think it's for the Home Office to answer for themselves. But for me, there's a sense of proportionality and pragmatism now in the application of the law. If our first duty is to save life, then there's a clear tension, isn't there, between upholding the law that says mere possession of a tiny amount of a substance should lead to either a police warning or an arrest that puts somebody into custody, that potentially exposes them to more drugs or different sorts of drugs within the prison system, which then puts them back out into society where the inequalities that's probably led to them, or the health issues that have led to them taking the drugs, will unfortunately for most of them mean at some point they're going to die. And statistically as well, there's an awful lot is said, particularly in Scotland, about this train spotting generation, my generation, 45 to 55. And depressingly, the names and the dates of birth that I'm starting to see come through on a daily basis are people in their mid to late 20s. You know, so it's not even train spotting 2. This is people who weren't around then. And it's growing in numbers. Of the 61,500 problematic users in Scotland, for the vast majority with a stigma, the end for them is, at the moment, death. And the criminal justice process, I think, is probably deleterious in that. It's actually pushing people into a place where there's more harm. And whilst it might be statistically an outcome that's a criminal justice outcome, it doesn't seem to me to present a good sort of social justice in terms of that rehabilitation, putting people back out into society that can be contributors to that. And certainly initiatives Kevin and Jason, what they're doing south of the border, there's a real opportunity for us in Scotland with the devolved nature of policing, but not this particular aspect of law, and the move to health to start to make great strides in that. But it's going to take real confidence and real courage. Because what I don't think we can have is what you've probably seen in Canada is police chiefs turning a blind eye to the law. I think that's the thin end of a wedge where we're there to uphold the law, not choose and pick and choose which ones and when we want to do it.
Cuban. Thank you. Following directly on from that, I wouldn't want to, by saying this, I wouldn't want to undermine anyone's position, say the Lord Advocate's position on prosecution of the management of a DCR, or an overdose prevention centre, and that also of the current Home Office stance too. But what I would say is that actually, following on from the Lord Advocate's position about prosecuting the management of an overdose prevention centre, if one should pop up in the current health emergency, actually is there the public interest to prosecute? And that's a comment that actually, I don't mean this loosely either. That's a very serious element for policing to take forward. If there is no public interest to meet that threshold for a prosecution, then the positioning, if you like, of the legislation standpoint is undermined by that health emergency. And there's another thing as well about language. As ACC Johnson's just mentioned there about this is an emergency. People's lives are being destroyed by drugs, and we have a significant issue with drug-related deaths. Language is really, really key to fueling stigma. DCRs give an interpretation of a loose kind of nature where someone can go in and shooting galleries pop up in the newspapers. They're not like that. They're nothing like that at all. An overdose prevention centre is a medical facility to look after those most in need, a very small section of a community that are injecting, poly-using, crack and heroin, injecting into their necks and groins 5, 6, 7 times a day. An overdose prevention centre, sorry.
I know we want to come on specifically to drug consumption rooms, so we'll leave that. Yeah. Tommy was wanting to come back.
Well, I'll let Superintendent Wilson first.
Sorry, from my point of view, I mean, my organisation treats people as vulnerable. What we're trying to do is work within the legislation that currently exists to be able to do different things. So we're trying to look at our own assisted treatment centres with partners, because there's we can do that with a licence from the Home Office. We're looking at what we do with low-level people who function in their lives around drugs, because within the legislation we can divert them from prosecution and we can give them an out-of-court disposal which prevents them going to court. So we do speak to the Home Office. The Home Office have been several times to visit the force, but the organisation of Durham Police wants to treat everybody at a lower level with current legislative guidance that's already there, and that's what we do. We don't break the law, we don't not arrest people for drug-related offences, we just dispose of them differently.
So can I just explore this a little bit more? Because it seems to me that we've got this situation in public policy now throughout the UK, more acute in Scotland, where you have you've got the body of Home Office legislation and practice, which I think is no longer fit for purpose, but no one wants to particularly change it, and they won't admit that. So there's an element within probably of embarrassment amongst within the Home Office that actually just will choose to turn a blind eye to certain stuff, or will allow some leniency if people want to push something and give dispensation for it. On the other hand, you've got this drive towards people trying to have alternative outcomes to alternative approaches to criminal justice to the problem, using health intervention and harm reduction techniques and all the rest of it, which you as practitioners on the ground seem to see merit in and are being dragged into that as well. So we have this sort of lack of clarity in terms of really what people should be doing and what is official policy, which gives you some discretion. And that brings us to what DCIQ was saying in terms of you presumably have to, in your operational policies, you have to make a judgment as to what the priorities should be, given you can't do everything all the time, and you have to decide which is better in the public interest. So, for example, we have 500,000 people using cannabis in Scotland every week. Technically, you could arrest every single one of them and give them a criminal record. I mean, that's the law, but you don't do that because it would be ridiculous. So you don't bust every student with a joint or every kid at a club with a pill or whatever. So I'm coming to my question is this. If someone were to set up a drug consumption centre in Glasgow or elsewhere, and to say this is an intervention that the crisis now demands that we do, would it be in the public interest for Police Scotland to close that down and to arrest people?
I think, so given our duty around preservation of life, I don't think it would be in the broader public interest. But from an officer perspective, so if you're an officer and you're walking the streets of Glasgow where that facility is, and you stop someone who's on their way in possession of those drugs, there's a hefty dose of the woulda, coulda, shoulda squad. So if the person doesn't then go to the safe facility and take those drugs where they have access to naloxone and medical support and medical intervention, but actually takes himself down off by the side of the Clyde and injects and falls in the river and dies, the woulda, coulda, shoulda would be, what are the police doing? You had a power, you didn't exercise it. That person should have been in a custody facility, put in front of the sheriff, from the sheriff to the courts, and we know the story. But that's a harsh reality faced. We see police officers making life and death decisions, albeit at the time it doesn't feel like a life and death decision, that's trying to base the pragmatism of preservation of life and potentially work with a facility like that. Yet society and the litigious nature of society is that would probably be a death after police contact, a referral to the PERC, an officer's life in turmoil for making what they thought was a pragmatic right decision for the right sort of outcome, but just didn't actually work out that way. So within the system, there's not that much clarity. There is a fear, because actually we should be, 1971. If 1,000 people died on the roads in Scotland, we would have seen changes in the Road Traffic Act. We'd have seen enforcement being different in that. But we would have also seen a systemic and whole system approach to that, which we have seen in terms of road traffic, in terms of building vehicle designs, preventative activity. So we're not seeing a consistency in the approach around the nature of harm. So when 1,000 of people die, it seems a little bit odd that actually 48 years after an act, when given the increase in technology, the proliferation of the use of technology in the commission of the supply, so this can be delivered to people's houses who are very, very vulnerable, very, very young, easy access, completely invisible to an awful lot of law enforcement or the medical profession. So we're not seeing the legislation keep step with society and the advances in society, let alone protecting officers who are trying to uphold the law for all the best intentions around preservation of life.
Yes,
I think this is fascinating because what we're hearing is the police creating ways to reduce the harm that's being done by the Misuse of Drugs Act, with police at local level saying this is if we actually fully implemented this law of criminalising everyone who we find in possession of these substances, we would be creating harm. So in the interests of serving our communities, we're not going to create those harms. We're going to find ways of not doing that. The problem is it then leaves police services and individual officers in invidious positions such as have just been described. And we asked earlier about the difference in diversion and decriminalisation. That's one of the advantages of actually decriminalising it and doing in the law, is you're reducing this ambiguity and helping the police in terms of giving them some clarity, both at the individual officer level and at the service level, as to what the government and the public wants us to do about drugs that actually does reduce harm rather than increasing the harms of this vulnerable population.
It almost strikes me like there's almost like a dishonesty going on here, where the government have got one approach that they've decided is going to be their policy towards drugs, and that's what they present to the public. They're tough on drugs, they're not going to change the law, they're sending out a message because of legality. And then we've got senior police officers and police officers on the street doing something entirely different. Wouldn't it be just much better just to have a consistency of policy and approach?
Yeah. I mean, there's two simple things that could be done to create some of that consistency. So, for example, the misuse of drugs regulations could be amended so that it was no longer an offence for a person who was employed by a drug consumption room to be in possession of a substance. That would help the police be clear about whether they do or don't arrest those people. And we could amend Section 8 of the Misuse of Drugs Act to make it clearer that people who are running a drug consumption room are not going to be subject to prosecution for running a premises that's being used for production of drugs. These are quite simple changes that could be made.
How could they be amended? Could that be done by secondary legislation?
The Misuse of Drugs Act is secondary legislation, so that would be easier than the changing the Misuse of Drugs.
So a statutory instrument could give effect to that?
The Misuse of Drugs the Misuse of Drugs Regulations 2001 already include exemptions, people who are exempt from the offence of possession. So you could expand that list of exemptions to include people who are working in a drug consumption room. And that would be very easy. I mean, there's a statutory instrument going through right now about correcting an error that was made around the banning of third generation synthetic cannabinoids.
Wednesday, that statutory instrument will be presented to Parliament. So.
Yeah, so it's a statutory instrument. It could be done pretty quickly.
Yeah. Okay. A couple of supplementaries. First, David Duckett, and then Hugh Gaffney.
Thank you, Chair. Actually, some of the questions I was going to ask there are already answered, but we've heard a lot about what can be done in Durham, for example, within the existing framework to do things differently locally. I would just specifically to ACC Johnson, is there anything more that we can be doing, or indeed are doing, within the current devolution settlement? Or indeed, is there anything we can learn from places like Durham that we should be taking note of in this committee to recommend to the government, without necessarily changing the Misuse of Drugs Act 1971, apart from maybe taking on board your suggestion for an amendment for consumption room staff? Is there anything more that we could be doing on the ground as Police Scotland to do things differently in the interest of improving public health?
I think, as I said, Kevin and Jason's work is something that we will look closely at and seeing how we might be able to implement something similar in Scotland. For me, there's three categories. You have your individuals who are substance users who, in many respects, and I don't mean this in the way that it might come across, who are particularly hopeless and helpless individuals who are victims. And they need society's support in moving away from their substance addiction in whatever means they can, and that's a clear health issue. At the other end of the spectrum, you have the serious and organised criminals that are responsible for supply and importation. And as I've already said, the approach taken to them doesn't link their activities with the harm that it's causing, the deaths that it's causing. And I think we should look at either legislation or an approach that targets them. And that's certainly what we have been doing in Police Scotland. We're targeting the principals, many of which don't even live in the United Kingdom, let alone Scotland anymore, and significant wealth causing significant harm in Scotland. And then there's a middle band that actually, and I think Kevin referred to it, it's the vulnerable people who are somehow involved in the trade and the supply. So whether they've been cuckooed or whether they're part of the county lines, these are vulnerable people who potentially have either mental health or other vulnerabilities, addiction, who are used in the supply of drugs. And that's an area of grey that I think the law enforcement, we would seek that clarity. But more recently in Dundee and only in the past week, we've just finished operations in Edinburgh, where actually the approach that we've taken is we'd approached the Lord Advocate about sort of the only way to actually deal with many of the people that we observe through some of our policing activity who are involved in buying drugs was actually for them to enter the criminal justice process. We had to arrest people to make the referrals, and what we were seeking to do was actually just make the referrals. So the recent Operation Fundamental, as I say, in Dundee, that saw around about 30 odd individuals arrested for being concerned in the supply of substances, but around about 100 adults and around about 30 young people referred to partners to try and get that support. But unfortunately, again, that referral had to come on the back of a criminal justice approach rather than referring as victims. And some of the blockers are things like GDPR. can we just share the information with partners that ultimately is about trying to keep someone alive? But actually, if it's a functioning individual who takes heroin, we can't share that information.
But you mentioned cuckooing and county lines there. Is there an opportunity to improve cooperation between Police Scotland and other police organisations across the rest of the United Kingdom that we're not?
No, we definitely do that. I think
Yeah.
Police Scotland, in terms of our database, which was probably one of the formations for the National Crime Agency, the database that now the whole of the United Kingdom in terms of the coordination and how the lines impact. So we have fairly good handles on the county lines, where they originate and where they with their final destinations are. And for us, it's predominantly the northeast of the country. But we've got really good lines on that. We've seen some good successes in targeting those. I think where we need to do it is, we've heard this from the previous panel, we've got to go at both ends of the spectrum. We really, really need to nail the suppliers, the importers and those that are causing the harm. We need to absolutely screw them into the ground and deal with them as robustly as we possibly can. And at the same time, try and take the market away, because I think as a previous person has said, is the laws of supply and demand are absolutely there.
Yes.
So even if you do legalise, they will all try and undercut the market.
Thank you for that. I'm just conscious we've got a big panel, so if we could maybe just keep our answers a little bit more concise. And being senior police officer, I'm pretty sure you're used to that. So, Hugh Gaffney.
I'm interested in your hamster wheel thing, because in Scotland just now the suicide rate is younger and younger. Is that the same with the hamster wheel? Are the kids coming in younger and younger? I mean, my local police station, I want to go out with them. They says you can't come out in the car because we've no cars. So, but we deal with the local police. They deal with the local vulnerable people, and they're saying if I arrest them, they go to court, they're going to get fined, they're going to come back and do the same crime again. But now I'm hearing that the judges are starting to say, what's the point? Do you think the politicians' power should be to make the judges send them back to a rehab or go for some of the stuff you're talking about? So there's two questions. Is the hamster wheel getting younger? And can we as politicians ask the judges to do something different?
I think the age thing is interesting. I think statistically you will see risk-taking behaviour from all young people. So whether that's with alcohol, drugs or other risky activity, we'll always see that. I think the activities taking place by these two gents in their jurisdictions are absolutely valid and a way for us of addressing that. I have a slightly different view from the previous panel insofar as some people, far too much is voluntary. And so many of these people, we're asking them to make decisions at a point in their life where my view, and I'm a cop, is are they really in a position to make those life-changing decisions and stick to them at that point in their life? And certainly, short-term sentences, we've heard 11%, unfortunately, will pass away within that month. Perhaps there's something in trying to drive down the level of drugs activity that exists within prison, a place where I believe society think it shouldn't take place, whether that's keeping the inmates passive. I don't hold with that. I think it should be free of drugs. And if it is, then we do need to make sure that if people go into prison, by the time they come out, they've had a full rehabilitation, not just the criminal justice rehabilitation, but their health and life prospects.
I'd like to add that that it's end to end. 1 in 11 adults consume a controlled drug. That's a significant market and supply and demand. But it's the early education and it's the consistent education within primary schools and preparing school children for that transition period into secondary education is absolutely vital. They're the next market, if you like, and some sectors that I've seen, they're sitting ducks. They're vulnerable to exploitation, and what diversion with the evidence that we're seeing from Thames Valley scheme is that this shows significant success in diverting young people away from the criminal justice system for education, but it creates another opportunity for the education sector to take on diversion in order then to reduce the number of school exclusions, to reduce the number of exploitable children and young people.
Thank you. Danielle Rowley.
Thank you. We were in Canada recently, the committee, and we visited a safe consumption site and heard about the relationship that they have and that the health services have with the police. And you said earlier, AC Johnson, about you don't really think the model of almost turning a blind eye is a good model. So if we were to overcome the legal barriers and have a safe consumption room in Scotland, what approach would Police Scotland take to ensure that it was safe? And
I think, Kevin's hit the nail on the head. These are vulnerable people that the police are sworn to protect. We've sworn duty to protect these individuals within our society. So we'll do as we do for all other vulnerable people. We'll work with partners. Mm-hmm. So actually, if it's a legitimate facility, we'll work with colleagues from the Scottish Drugs Forum, with the health service, whichever agency they come from, to try and get the best outcomes for the broader society. Many of these people commit secondary crime. The possession and the drugs taking is one aspect of that. And certainly, I can speak from experience, I'm sure the gents either side of me, when you're sitting in custody and somebody comes off these drugs, 9 times out of 10 it's disbelief of what they've done. Mm-hmm. And that's cold comfort. If they've assaulted someone or they've stolen something, there is another victim out there. But on behalf of society, we can't keep pushing people through the hamster wheel. We've got to start to shorten that learning cycle. And it feels to me that we've reached that point that we are the fly that's flying into the light bulb so many times and getting burned. I think we have to be the generation that starts to say, no, actually, we can learn, it's working somewhere else. And if that means building a relationship with partners and that person enters those facilities, starts to access and mainstream services, starts to address their underlying issues, that's got to be good for us because we're not putting them through expensive criminal justice processes. But it's actually much proportionate with the legitimacy that we seek as law enforcement of actually keeping up the whole of our community safe.
And can I ask, you said that there's not an area in Scotland that isn't having a rise in drug deaths, but there must be different types of drugs in different areas and different types of drug use. Is this something that local authorities need to have a bigger role in how work is designed on the ground? Obviously it might be different in Durham from how it would be somewhere else.
Definitely. All partners, I think all partners are engaged in that. Our recent report on the profile, 45 different drug types, and these are the drug types that are found in the post-mortem toxicology of drug deaths in Scotland. So 45 different contributory drugs across the whole spectrum. And in there, you would expect that you would find alcohol in there as well, around about 17% of people that have alcohol in the system. So it's a huge range of drugs right across the whole of the country, and that's about availability, supply, the criminal patchwork and where they're getting their supply from. Some of it medicinal and misuse of medicinal supply. But the local authorities, from Jason's point around early years prevention with education, through to health provision, through to safe social spaces, the nighttime economy, the daytime economy, there has to be a whole holistic approach. And for me in Scotland, we've got an ideal opportunity. The leadership moved from criminal justice to health. I think what it now needs is that leadership and strategic approach that's outcome focused rather than performance focused. And it sounds betwixt two places, but if the outcome is preservation of life, and I don't know how you put a measure on that in this instance, but actually everything underneath then starts to see, I think, an improving picture. And the police will find its role in that will clearly be about enforcement of the law, whatever that is, but it should be, for me, about preventing vulnerable people from falling victim to criminality and targeting those that cause the most harm.
Can I come in this question on internationally how police services deal with the presence of a drug consumption room? In the UK it's not that much difference from the legal challenges presented by a needle exchange being in a community, as many communities have. But there are examples internationally where people have gone further. So, for example, the drug consumption room in Vesterbro in Copenhagen has around it a police-declared non-enforcement zone for possession offences. So within that zone, people who use drugs will know that they're not going to be arrested and punished for possession of substances. And the research that's coming out of that is showing that's improved the relationship between the people who use drugs and the police in that area. It should be mentioned, well, two things. One is that is a group of people who are very highly victimised. So people who have problems with drugs suffer rates of victimisation, including violent victimisation, that are far above the rest of the community. And the second is that that's a useful source of information for the police to do their work. So, for example, in Portugal, the police, when decriminalisation was being decided upon, were initially quite reluctant because traditionally a very good source of information about the operation of drug markets is people who get arrested for low-level drug offences, and the police were afraid they would lose that intelligence. But what they found was that by improving their relationship with people on the streets, because they weren't threatening them with arrest, then they were still getting good intelligence that they could use to look at higher rates of the market. So I think, again, decriminalisation provides a framework where the police can be clear about improving their relationship with this vulnerable community that they're working with.
Okay. Anybody else? Ross Thompson.
Thank you very much, Chair. I know you've kind of touched on the county lines issue, but my question is round about, and it's directly to Mr Johnson, which is about what Police Scotland is currently doing to reduce the supply of drugs in Scotland. So you might be able to maybe touch on maybe some of the drug trafficking, whether that's opium production coming in from Afghanistan, whether that's cocaine production coming in from Colombia, which we know is at record levels, and maybe what you're doing at ports, airports, and even vehicles and that coming in to try and reduce that income.
It's a broad spectrum, and it's an ever-growing spectrum. So we work very closely with colleagues south of the border in terms of the county lines and where they originate and then come into Scotland. On an international level, the organised criminality in Scotland has a landscape that covers five continents. We work with the National Crime Agency and their network of liaison officers. We have good relationships with the FBI and the Drugs Enforcement Agency and our counterparts right around the globe in trying to target that. Interestingly, one area that it would be remiss of me not to mention is it's actually not unlawful to buy a pill press. And the constituent parts for many of the drugs actually come in various levels of control. And one of the things that we are seeing in Scotland is a real desire to provide pill presses. And the benzodiazepine market, I think a colleague may have touched upon it, seems to be trying to fill that void around some of the minimum unit alcohol pricing and trying to fill that void. So we're seeing organised crime groups trying to buy pill presses. And it seems remarkable to me that actually an organised crime group can go out and buy a pill press that's completely unregulated. Why would anybody want to provide a pill press that produces 40,000 tablets in 12 hours and then floods the market with illegal drugs? So everything from the chemical precursors to the machinery to make the drugs in a usable format, right the way through to the importation and the exploitation that goes on in terms of that, including coercion of officials, is something that we are engaged in. And we have some good examples. I think you'll have recently seen the operational engagement trials in Scotland, Operation Escalade. They're still very much ongoing operations targeted at the higher echelons. There's a lot more to do there. And I think an approach that frees up some of our criminal justice activity, the officers on the ground, to support vulnerable people still, very much community-based, but then re-emphasise and target those causing the most significant harm. And that's going to really challenge us because, as I say, most of that effort is abroad. It's people who don't even reside in Scotland. Their money, their wealth is amassed outside of Scotland, but the harm is felt there. And we have to do that alongside National Crime Agency and other international partners.
In terms of the wider drugs trafficking sort of industry, I know that would also involve money laundering, arms, modern day slavery. I wonder if you could touch on what Police Scotland is doing in those kind of areas as well to...
Absolutely. So one of the things that we do have in Scotland, as you'll be aware, is the Scottish Crime Campus. 21 agencies there represented. So we do an awful lot of work. One of the most recent partners that's joined us is the Department for Work and Pensions, where we actually saw vulnerable people being housed in locations and then basically being taxed for their benefits and their rent. That was alongside, potentially, the use of those people in the sex trade, also those people in use in terms of the supply of drugs, and being treated as a commodity themselves. We have an approach in Scotland, because of the Scottish Crime Campus, where we have a multi-agency tasking, where you already heard of the Al Capone. I don't care which one of the 21 agencies in that room uses one of the pieces of legislation that they have to bring that organised crime group to their knees, so long as we do it. So whether it's the tax people, it's normally the tax people that can get people, or whether it's DWP, or whether it's environment protection, whichever piece of legislation we can best use to bring that organised crime group down and then support the vulnerable people. The switch has been making sure that we're joined up with the local authorities, the health providers, and that's where some of the challenges come around information sharing of it's difficult sometimes to share information other than anonymised, which is useless when you're talking about victims. It has to be personal.
Thank you. Tommy Shepherd.
So I want to come back to this question of whether the current legal framework is a help or a hindrance to you dealing with the problem on the ground. I mean, the experience from Portugal and elsewhere seems to suggest that if you do create a sector within drug use which is not criminal or not criminalised, then that allows law enforcement authorities more ability to focus on the elements of criminality in terms of supply routes and all the rest of it. I mean, even the person who would advocate the most liberal reforms, for example, would insist that the purpose of a legal regulated framework is to take action against people who operate outside it. So if there were people who were bringing in, who were trying to put stuff in the streets that was cut with poison, if they were trying to push to kids at school or whatever, you could focus energy on that. To what extent would a change in the law assist you to prioritise your activity on the real criminal aspects of drug supply?
I think for me, we need to look closely at the evidence of Portugal. They had 16 drug-related deaths last year, so clearly decriminalisation in that legal context is working. And emulating best practice from the Portuguese Dissuasion Committee model into our diversion scheme principles hopefully is working to reduce drug-related harm. But for legislation, diversion does create better outcomes for the person, better outcomes for the police, freeing up resources, less demand, but also higher harm reduction and better outcomes for that individual concerned in the first place. So regulated markets, my view is an open mind, really. I think we need to look closely at the evidence of Canada and how that pricing framework is going to impact and lessen the availability of harmful high THC cannabis to younger people, for instance, because that market won't go away in any regulated market. So it's how that model reduces harm to those risk groups. So, but I'm not a professional or expert when it comes to regulated models, I'm afraid.
I think the demand on the police from a low-level point of view around low-level crime, and particularly drug-related offences, is vast. I think there's the dichotomy between targeting the people, as the ACC said, who operate at the top level, who are not necessarily drug users, but use it as a medium to make money, versus the massive demand that we have every day around all the other externalities that you get around mental health, alcohol and drug-related criminality. 32% of our demand in Durham is crime-related, the rest of it isn't. And lots of those people who are drug abusers and drug addicts are operating across the whole gambit, not just the criminal aspect. So I think if we did some sort of decriminalisation, would we arguably reduce the demand at a low level for the beat officers and our response cops? Yes, I think we probably would.
I'd just like to add to that, as somebody who's written quite a lot about Portugal and its decriminalisation model, I think one of the most important things to remember about Portugal is that they didn't just decriminalise drugs. They expanded treatment system substantially, mostly through getting more people into substitution treatment at low threshold, but they also improved their welfare system. So they introduced a guaranteed minimum income. And the whole point of the whole package of measures, which included decriminalisation, was to reintegrate or indeed integrate people into society. So the demand that you're talking about is from a group of society who've been excluded across the board, and their criminality and their contact with the police is just one aspect of the way that they've been excluded. These are people who've been in care, suffered brain injuries, been excluded from school, homeless. And there's a whole range of issues that we have to deal with those people in their complex wholeness, rather than just saying we can solve this problem by stopping criminalising them. Yes, we should stop criminalising them, but there's other things we need to do to support those people to live full and healthy lives.
Thank you. There's a public narrative as well that we would need to address. I think a number of people, I think you've heard evidence about the stigma. And any suggestion of decriminalisation, legalisation is always met with it's the police going soft on drugs. And I think it's far from that. It's actually the police being very pragmatic about the nature of the harms that are experienced within the communities. Most of the communities will know these people themselves. They see them as helpless, hopeless individuals within the community that should warrant the full support of all the social systems that can try and help these people overcome their health issues. But whilst it remains the responsibility of the police, and had remained the responsibility of the police, the only approach to dealing with that was through the criminal justice. So any legislation that would see vulnerable people treated as a health issue, as a vulnerability where people need that social support and health support, I think would be welcome. And then the delineation to those that cause the harm, as I think your point made is those that bring in the drugs, those people that do the cuckooing, the county lines, the mistreatment, the exploitation of vulnerable people in our society. We should absolutely then, any resources that we free up in one hand, refocus them on making sure that those people are brought to bear, and actually that the punishments reflect the harm that they cause, because at the moment it does feel very white collar and has very little correlation to, no drug dealer who's imported multi-kilos of heroin ever gets mentioned about the number of heroin-related deaths in their charges. But actually we should be talking about that, because I believe there's a direct correlation to the drugs that these people bring in unlawfully and the deaths that occur on our streets.
So it sounds as if, as senior police officers, you would welcome a change of the law to allow you to reprioritise your actions.
I think so, yes.
I think we're all really impressed with what's happening in both Durham and Thames Valley, and looking at some of your statistics and what we've heard from you, DCQ. It is impressive what's been achieved, and we congratulate you for what you're doing. I'm just wondering, for both of you, what you're currently doing in operation and practice, how that would differ from actual decriminalisation. Is it? It almost sounds like de facto decriminalisation. So what would be different about how you would approach these operations if drugs or cannabis particularly was decriminalised?
At the moment, Thames Valley scheme still records the crime, so hence we're not decriminalising. There's still a record of that intervention, interaction with the person involved. What the community resolution does, it affords an opportunity for that case not to appear on a DBS check. So when someone's later applies for a job, that doesn't show up and destroy their future opportunities. And community resolution is within the current legal framework, as you know. Decriminalisation, I can't, this is hypothetical really, but I can't imagine too much difference in the dissuasion committee model that Portugal operates. It's a robust, proven and evidenced process.
Okay, what about you?
Yeah, I think from my point of view, what we find with people who we arrest for drugs offences, they've got other issues as well. So we take the view that we have to sort out all of those issues as well as the drugs. So our aspiration would be that we don't arrest people, we actually stop them on the street and divert them into treatment that they need across the whole gambit of offences. So we work with 300 partners to try and divert people. The cops have the ability to log on to see what diversions are available. And I think taking out the drug market would just mean that we'd be able to deal with the people in a different way. Just drugs wouldn't be the factor that decriminalise them. It would be the other issues that they've got that we try to help.
And in Scotland, of course, it's recorded police warnings, which is really the model which has been adopted there. I mean, and it does differ in a number of ways from what we're hearing from both your colleagues. Would Police Scotland consider one of these schemes that have been outlined, the checkpoint?
I think we have to. I think we've got to look at the evidence base. One of the things that we do is evidence-based policing, and we've got to look at what works elsewhere. Clearly, we have to liaise with the Lord Advocate and the Crown Office around what we can actually do, because much of the practice is set through the devolved nature in Scotland. But again, I think Police Scotland can provide a track record of trying to be innovative, making approaches to the Lord Advocate, to try and change our approach, which is to address and try and implement similar work that the gentlemen have introduced here. And as I said a number of times, because of the devolved nature in Scotland, we've got a better chance than anywhere else. We haven't got the patchwork quilt. Two forces out of 43. For us, it's one force. It's one country.
Yeah, and that's what strikes immediately apparent. I mean, you have a much more, I suppose, scope to manoeuvre, to do these type of things differently with the devolved responsibilities in Scotland. And we're speaking to the Scottish Government Minister next week and the Lord Advocate, so we'll maybe be able to put that to them directly. Daniel Rowley.
One of the things that disappointed me when we visited the consumption site in Canada is that they had different bodies within the centre to help, but they didn't have anything targeted at women. And I've seen through my own work in my own community women who are trapped in abusive relationships because they're an addict and that's where their supply is. And we know that from speaking to families that have been affected, that there's a lot of different issues for women when you look at drug misuse. Are there any examples of good practice that's going on where women are being helped, or any recommendations or research that you might have done?
I'm aware of good practice within drug services that operate women-only spaces and women-only session times as well. And that's a holistic approach to identify any domestic abuse elements of that, controlling an addiction to promote health and to promote health. So yes, there is good practice out there.
Yeah, I think from a checkpoint point of view, we take domestic abuse offenders and victims on as part of the scheme. It's been really successful, particularly around women who are offenders and victims. We've got lots of evidence that we're busy writing up at the moment about why women commit offences for different reasons to men do. So there's now a body of evidence around why they do that. And it's some of the things you've suggested, you know, lots of stuff that women offend for is because they've got no self-esteem, because of relationships. Men don't seem to have that. So the people who work for us to divert these people are actually trained in those skills to deal with women-specific offending.
I think there's sometimes an extra barrier as well for women. We heard from a former drug user that she would never have reached out for help because the fear of getting her children taken off her. And I think that creates an extra barrier for the police to connect sometimes with families as well.
But we work really close with social services when we're formulating our contracts to understand that and actually, in a lot of ways, it works because it's a sword of Damocles. Work with us, improve your life, and actually you'll not get your children taken off you. And it seems to work. It's been one of the big successes of Checkpoint.
Okay, thank you. I'm just wondering, all these projects that you've got, it seems to be operating within, I would describe it as a grey area, but as an interpretation of the current legislation as defined by the Misuse of Drugs Act. Would that be a right characterisation that you're able to do these things because you've looked at the legislation and you've decided that you can, in terms of your operational independence, are able to put forward these schemes? That would be roughly right.
No, I think some years ago the government changed, certainly in England, the ability for police to give out-of-court disposal, so it was a police decision to prosecute. Right. So that covers some serious offences as well as others, and not just how we dispose of people.
I'm wondering if they could give you this, and obviously you have a degree of operational independence. Yeah. They could easily just take it away again, couldn't they? They could just say, well, public opinion is such that we've got to be tougher on drugs. We've got to respond to a Daily Mail campaign or something like that. So all this could be. All this could be taken away if they decided to do that.
It already is being taken away for a particular group. So the Home Office, for example, has made it clear that it will tolerate local police services working with drug checking agencies at festivals, which largely deal with white, middle-class young people. But it has said it won't tolerate police services working with the drug consumption in Glasgow, which is going to save the lives of mostly middle-aged working-class people. And I think there's a real discrimination there.
But I'm just wondering, in the views of the police officers, isn't legislation required? I mean, it's fantastic you're able to do all these things with the interpretation of the law and some of your operational independence, but I'm just wondering where it rubs up against what the government has in terms of its objectives, approaches and policies.
I think there's a need for legislative change, and I think that would help us dramatically.
DCQ?
I was thinking it from a different perspective, but I think the current climate gives an opportunity for innovation, actually, and any decision for to implement a scheme within a local police force is a local operating one for that chief officer to make. And whilst we do have to acknowledge and be very, very careful, of course, is the postcode lottery effect of the current patchwork of schemes, such as our difference with Checkpoint.
Hugh Gaffney, want to come in? Yes, and Tommy. Hugh.
Yeah, just all these schemes and the Checkpoint and the schemes we're all doing, have you, advisory committee, given that to the government to say why we're not rolling this out? 3 years now Checkpoint's been going. It sounds like a good success story. So why is the advisory council not telling the government, and has the government reacted to it?
The Advisory Council works on a mixture of being commissioned by the government to look at things and also by choosing things it can, on its own behalf, take to the government. And so there are some things we have taken initiative to take to the government. We tend to choose those on the basis of how much social harm we think is being created and how much evidence there is to use to provide an evidence base for the government. At the moment, the main priority that I can see is reducing drug-related deaths. And we've taken evidence on that and produced reports on that. And there's very strong evidence on how you do that around opiate substitution treatment, heroin-assisted treatment and drug consumption rooms. At the moment, there hasn't been peer-reviewed evidence coming out of these schemes. And there isn't yet very strong evidence that these schemes on their own will save people's lives. That might occur, but at the moment we're seeing good indications of effect in reducing crime and being more effective than other forms of punishment. But we're not yet seeing strong evidence, gentlemen, of saving lives. So it's a question of both the prioritisation of the issues that are being addressed and the amount of evidence that's available to use in advising the government that has probably prevented us from doing a specific report on these types of schemes. I have recently written a report for the Irish government who's looking at decriminalisation, and we've included some of the evidence that is coming out of its schemes, and I'm happy to share that report to you when it's freed up by the Irish ministers.
Just on that point then, has Checkpoint improved over the years, over the 3 years? I noticed there's 42% of the figures that people have entered it, but only 42% have been saved. So is that percentage going up? Is that a time factor thing? You know?
Yeah, I think it's now been peer-reviewed, part of it, and will continue to be. We ran a randomised control trial, which we're waiting for next year, which will have 2 years post-trial. I think that will be evidence that's accepted. Indications are that there is a reduction in reoffending rates, but also there's a reduction in self-scored by the people who go onto the scheme. So actually we improve their life chances, and that seems to continue. So the reoffending rate for the control group is going up while the treatment one is stabilising. So I think in the next year or so there will be some really peer-reviewed evidence which would say that Checkpoint does work, and it certainly works for drug offences.
So I'm intrigued by this question. We've got two representatives of two English forces in front of us who, and we've invited you here because you're doing interesting and innovative stuff. And I think in each case the PCC is given the political backing to this, as it were. What I'm now curious about is to whether or not you guys are on your own in terms of the general view of operational police managers in this country, or whether you think your colleagues in the other forces who maybe they may not have the same particular schemes that you have in operation, but whether the general feeling is there that actually the 71 Act now needs to be changed, repealed, overhauled, or whatever. Would you say that that's... And of course we see an awful lot of former police officers who, no longer constrained by office, are actually joining in the campaign for legislative change. So do you think this is now the settled view of the police service throughout England, that the law needs to be changed? And to Steve Johnson, what you presumably are in contact with, you talk with colleagues in other forces. Do you think that this is something that should be reflected in Scotland, if indeed it is a significant overall change?
Yeah, I was just thinking then, for the Act to have come into force in 1971, that means most of the work was probably done in the late 60s. If you think back to the late 60s, I'm just about able to remember that. Actually, the technological advances, the science advantages, the distribution networks, in many respects, this one aspect of policing, and even the title misuse of drugs, or the supply of drugs and the use of drugs within our society, if there's one area that is ripe for a refresh of the legislation and a refresh of the evidence base, I would suggest it's the Misuse of Drugs Act 1971.
So, well, are your two forces the exception that proves the rule, or are you out on a limb?
No, I think from our point of view, I think we went alone. It's supported by the Chief Constable, and it's supported by the PCVC in Durham. There's trial areas. The Ministry of Justice looking for 4 trial areas, which they've got, I think, in West Yorkshire and other forces. And there's also 4 other forces in the country who are currently running whatever their force is, checkpoint schemes. So I think, not just in relation to drugs, but across the whole critical pathways agenda and the diversion within the law, lots and lots of other forces are coming round to the issue that we've got to do something different, and if other people can't do it, then the police will have to do it in consultation with partners. Whether that means that they all agree that there should be changes to the Misuse of Drugs Act, I guess lots of them do think they should, but I don't know anybody who would say that. but it stands to reason that if you're trying to work with people to reduce the harms they cause because they're vulnerable people themselves, lots of British policemen would think that you should reform them.
I mean, obviously can't speak on behalf of all the police forces across the whole of the United Kingdom, but did the Police Federation, for example, take a view on this? What is their current approach to the Misuse of Drugs Act? And how would we get a view of the police force, if you want to call it as such, across the UK on this issue?
Yeah, the Federation have come out, I believe, for a public consultation on drug policy towards a health-based approach. That was at the last conference.
Okay.
Correct me if I'm wrong on that.
Well, we'll see if we could locate that then.
But there is a national working group within the National Police Council for out-of-court disposals, which is what our scheme fits within, and that of Checkpoint. So there is an appetite nationally for change for a number of offences, not just drugs. And yeah, we're moving in that direction. But I think if you collectively asked the opinion of most police officers, dare I say this, but I think there is a general appetite for a health-based approach to simple possession. Okay, thank you.
I think the national position, the National Police Chiefs Council and the National Police Chiefs Council lead could obviously provide that view on behalf of the police service as a whole. I think what's really interesting is from a police service, I think we're very good at where we're responsible and accountable. We take the lead, and we take the lead with pride, and we get stuck in. I think we find ourselves in a difficult position where we've been in the lead. I think all the informed wisdom is that this is a health issue. I think one of the interesting things is are health happy now to take the lead?
Yeah. Yes.
You know, so we can talk about changes in the legislation from an enforcement perspective, but actually health service will need a change in the legislation as a key enabler for them to do their work. And I think seeking the views of senior police officers and the National Police Chiefs Council is one thing, but actually the health service as well, if this is going to be seen as a health issue rather than just the police saying it is, then that's going to need an enabling framework.
And that would imply a change in lead responsibility at UK level, from the Home Office chairing the UK Drug Strategy Board to the Department of Health and Social Care chairing the Drug Strategy Board. So the health is clearly in the lead. And I also think, going back to an earlier question of evidence, that would, if the Department of Health and Social Care were in charge of drug policy and coordinating drug policy across departments, then the Department of Health has a more institutional commitment to the use of evidence and spending money wisely on the basis of evidence than does the Home Office. So I think that would also have the effect of introducing a more evidence-based approach to drug policy if the Department of Health and Social Care were in charge of it rather than the Home Office.
And we all remember the example of Professor Nutt when he was presenting his particular proposals to government, and the way that the press campaign was always organised and orchestrated against what he was saying. It was still in that territory, do you think, when it comes to the Home Office responding to?
I hope not, but there's been a backward step recently in that regard.
Okay. Well, gentlemen, thank you ever so much. Again, fascinating session. I think we've asked for a couple of other bits of evidence, which I'm sure you'll be able to supply us with. But again, if there's anything that you feel you could usefully contribute to this ongoing inquiry, please get in touch with this committee. But for just now, order, order.
The proceeding has ended. The proceeding has ended.